much is doing cesarean myomectomy among the faculty?
Dinesh, we have to answer in the chat box because Arul, Kumar and sir and everybody is waiting. So they will, so question answer will be in the chat box only.
MOC can continue, please.
Yeah.
Sure.
So please continue, yeah.
Okay. Should I invite Dr. MC Patel for his talk?
Yeah. Please. Go ahead.
Okay.
We're getting late already.
Yes, ma'am. Sorry for that small technical glitch. I would now like to invite our next speaker, Dr. MC Patel, sir, who is a very senior consultant at Ahmedabad and past Vice President of FOGSI and Organizing Secretary of ICOG 2017. So I welcome you for your talk.
Thank you for kind words. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that. Consent in operative delivery, the subject given to me for today's talk. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank ICOG team under able leadership of Dr. Mandakini and of course Dr. Mitra Saxena and Surekha Taide for inviting me to share my views about the subject. I always start my talk with this sentence, is it worth discussing? Yes, always yes. Then why? Let us see the statistic of Professional Protection Scheme, which is run by IMA Gujarat State Branch, and see the increasing number of enrollment of membership and see the increasing number of litigation faced by our friends. Last year only, out of 15,953 friends enrolled, 2,652 friends were facing litigation in one way or other, either at notice level or district forum, state commission, national commission, or in any other courts. So it simply means medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists friends rank first as far as medical consequences are concerned. And this is the very famous case as far as consent is concerned, Samira Kohli versus Dr. Prabha Manchanda, which was decided in Supreme Court in January 2008. It is landmark case because consent in Indian context was decided and discussed at length in this particular case. And this case has been referred to and cited several times subsequently in so many of the cases. It was an interesting case because it was related to gynec laparoscopy surgery. Case was like this. I will be very quick and fast. Unmarried 44 years patient, she was subjected for diagnostic laparoscopy for fibroid, chocolate cyst, and small cyst on left side, that is query endometriosis. So, but consent was taken for admission, treatment, and diagnostic laparoscopy. She was explained surgery to be minor, laparotomy may be required was explained, but she was not explained about hysterectomy. She was not explained about alternative modalities of treatment. And during surgery, there was some problem and doctor had compelled to go for open abdomen and total abdominal hysterectomy. Assistant took consent for hysterectomy from old mother who was waiting outside, and ultimately hysterectomy was done. So case was filed and allegation was hysterectomy done without patient consent when patient was under anesthesia, no preoperative information about alternative modalities of treatment, and she suffered premature menopause afterward. So point in issue in this particular case was, can the doctor be held negligent for taking decision of total abdominal hysterectomy on table? No, doctor was not held negligible for taking decision of total hysterectomy. So thank goes to Dr. Sudha Salan, who had been an expert witness, and she gave her expert witness that it was need of time to save life of patient, to control bleeding. It was very much necessary. But again, point in issue in this particular case was, is doctor still liable? Yes. Then for what? For assault under Indian Penal Code section 351, that is battery, for doing total abdominal hysterectomy without consent. Consent was taken for diagnostic laparoscopy. She was explained about laparotomy, but laparotomy may be needed means it implied conservative surgery and not total abdominal hysterectomy. So compensation worth rupees 25 lakhs was demanded by patient, but it was awarded only rupees 25,000 plus bill if paid, which was not paid, and 5,000 against cost only for lack of consent. So doctor was not held negligent for doing total hysterectomy in this particular condition, but lack of consent was taken into consideration in this court. But in this during this particular case, court has decided concept of consent in India in a very detailed manner. So they decided what is valid criteria when consent becomes valid. So first criteria is capacity or competence. Who can give consent? Any adult mentally sound patient can give consent, and nobody else can give consent on her behalf. If patient is minor, if patient is mentally challenged, then guardian may give consent. If it is an emergency, no consent is required, but at the same time, burden of proof is on shoulder of doctor to prove that it was emergency, it was dial emergency to save life of patient, then no consent required. Consent should be voluntary, it should be free, signed by patients only, just I mentioned, and others are witnesses only. It should be informed consent. Are your patient properly informed is very much needed. Patient should have knowledge, nature of treatment you are offering with all its benefits and side effects. No fraud, no coercion, no false promise. And you should offer all the available alternative of treatment, and then only a consent should be taken. You are under obligation to explain about success rate also in your clinic, in your city, in your state, and in your country. Refusal of treatment. Many a times patient may refuse to give consent. So you are under obligation to inform patient about all this high risk condition or any other risk involved during surgery or any treatment modality you are offering. And you also to explain possibility of injury to surrounding structure if you are going to go for cesarean section, and all other possibility of probable complication. You have to also explain about if at all there is allergy towards drugs or so, fistula formation in future, placenta previa possibility in future, adherent placenta possibility in future. So this type of certain risk factors you have to inform. Possibility of blood transfusion should also be explained prior surgery, and outcome of baby should also be explained before going for consent for cesarean section. As far as anesthesia is concerned, separate consent for anesthesia should be taken, and at the same time it should be explained about nature, benefit, purpose, effects, and alternatives which involve substantial risk of anesthesia. As far as blood transfusion is concerned, same purpose, effects, alternatives, and substantial risk involved should be explained. So, does consent require for blood transfusion? Yes. In this particular case, court has held that doctor is required to get two separate consent from the patient, one for surgery and other for blood transfusion, because surgery involves risk and blood transfusion involves additional risk. So, question was asked that does Supreme Court expect us to talk about all possible complications at the time of taking consent? So it was clear, expected to anticipate certain complications or requirements depending upon the condition of the patient. And at the same time, no need to explain remote or theoretical risk involved, which may frighten or confuse the patient and result in refusal of consent for necessary treatment. And if patient refuses to give consent, then need to explain risk of refusal of treatment also. But at the same time, no need to explain remote or theoretical risk of refusal of treatment, which may persuade a patient to undergo fanciful or unnecessary treatment. So balance should be maintained at the time of explaining everything to the patient. One more criteria. Should consent be written? Is it mandatory? There are 3 conditions under law: organ transplantation, PCPNT Act for ultrasonography examination of antenatal patient, and case of medical termination of pregnancy, in which written consent is very much mandatory. In other condition, you can go with oral consent, but burden of proof is always on your shoulder to prove that you had counseled patient and patient has given consent, and it is very difficult in court of law to prove. So though it is not advisable, mandatory, but it is always advisable to go for written consent to make a consent valid and real. So always written consent. Consent can be taken by assistant doctor also. Lower segment cesarean section with female sterilization. In this particular case, during cesarean section, tubectomy was done and case was filed that it was without consent of the patient. Defense on part of doctor was, during operation found next pregnancy to be dangerous. Patient was asked, but this patient was operated under GA, and under GA consent was not possible. So case was allowed in favor of patient. So if you have not taken consent for tubal sterilization, you cannot go with during cesarean section for tubal sterilization, even if you find that next pregnancy could be dangerous, because it is not immediate danger to life. Still, patient has time to decide whether to go for next pregnancy, whether to go for tubal ligation after this cesarean section. So if you are in a little doubt, then this patient may need female sterilization operation, then you should take consent prior at the time of taking consent for cesarean section. Does consent of spouse required for female sterilization operation? Yes, consent of spouse is very much required, because in one of the cases, Supreme Court has said that when you are going to put full stop on reproductive capacity of couple, then both the partner should be taken into consideration and consent should be taken. Lower segment cesarean 6 with myomectomy. Dr. Alka Kriplani madam has very nicely taken this subject, myomectomy, just prior. So can one do myomectomy with lower segment cesarean section? No and yes. When no, if consent is not taken prior, and when yes, if it is life-saving and immediate danger to life, if it is not removed, then you can very well go with myomectomy even without consent. But if there is no immediate danger, if there is no life-saving operation during that particular period, then you cannot go for myomectomy if you have not taken prior consent. So, and at the same time, you have to explain about all facility to deal with myomectomy at the time of cesarean section to the patient at the time of taking consent. So person should be experienced to deal with the situation of myomectomy during cesarean section. Possibility of blood and blood products is always there, so it should be readily available to deal with the situation with all availability of blood or blood product, and prior consent is very much must. So one more thing, can one take a common consent, say for example diagnostic and operative procedure together, or for particular surgical procedure and additional or further procedure? Yes, but it should be prior, just like cesarean section and myomectomy, cesarean section and tubal ligation. So consent given for specific treatment, one cannot do other procedure unless it is life-saving. An argument that it was beneficial, would save time, would save pain and suffering in future doesn't stand in court of law. If it was not immediate danger to life, and if you have extended scope of surgery, then you may be put into trouble as far as legal consequences are concerned. So whenever there is extended scope of surgery or scope of surgery change, fresh consent is very much required. Can it be taken on pre-printed form? In very recent past, in famous case of RG Stone Hospital versus Dr. Vinod Agrawal, judgment came that you cannot take consent on pre-printed form and you cannot take blanket consent. And in this particular case, compensation of worth rupees 10 lakhs was awarded in favor of a patient. But this case is challenged in Supreme Court, and court has granted stay, and we are very much likely to win this case, and we can have a consent on printed form also. Is it necessary to take consent in vernacular language? If your form is printed in English, then you can very well go with consent in English also. But at the end of consent, you have to return one simple line that it was, whichever thing is written above, it was explained to us language we could understand by doctor or by interpreter, and after understanding everything, we have signed. And once patient and relative signs, then it is valid consent, even if it is in English and not in vernacular language. Is it compulsory to take in vernacular language only? So I have explained that. Who should sign consent? Just I have mentioned, patient if major and mentally sound herself. Then if patient is minor and mentally challenged, then guardian. And relatives are only witnesses. They cannot give consent when patient is adult and mentally sound. One more questions come. Should doctor sign the consent form? Yes, because under Indian Contract Act, unless and until contract is signed by all the party involved, contract is not valid. And when you accept patient to treat, it becomes a contract or implied contract between patient and yourself. You are offering your expert services, and patient pays for that, or patient promises to pay for that. So it is contract between you and patient. So unless and until it is signed by doctor, this contract is not complete. So consent should be signed by patient, in case of minor, guardian, witnesses, and doctor. Two witnesses, one on part of patient and one on part of doctor. In this particular case, it was very decently said that consent is not mere piece of paper where patient or relative signs, but it is a document of your communication, which you counsel to the patient, which you communicate to the patient about treatment modality or surgery or procedure you are offering, and then only patient signs it. So it is a documentation of your communication. And as far as every complication of operative delivery is concerned, they are having a potential threat. So look like avoiding medical problems in our practice is a difficult balancing art. No, not at all. So what to do and how to prevent it? So practice foreseeability, anticipation, good communication and consent, and documentation, and you will be simply sail through. So as far as foreseeability is concerned, if you are dealing with a case of placenta previa and cesarean section, then naturally you should anticipate that there may be possibility of postpartum hemorrhage, and you should be readily available to deal with the situation accordingly with blood transfusion, blood product transfusion, or even in few of the cases, hysterectomy also. So foreseeability and anticipation is very much required, and it is good defense in your favor. And of course, proper counseling, and it is very obvious. More is the time you spend with the patient in counseling room, it is very obvious that less is the possibility of you needing to spend time with that patient in courtroom. And communication is key to avoid litigation, and it is very obvious. We might have the best medicine in world, but it won't be successful if patient doesn't understand it. And when we start our counseling, usually we start with this: what is your complaint? And there are so many questions on part of patient. Why did it happen? Will it happen again? How it can be avoided? Could it have been avoided? So at the time of counseling, you are under obligation to explain about all the alternative modalities of treatment with morbidity, with probable expense, in high-risk cases, probability of mortality, with prognosis, probable complications, possibility of blood transfusions, risk involved, and it should be in a common language. No much medical jargon. You should explain everything to the patient in a language which patient can understand. And no rosy picture about result, no tall claim, because when you claim to be master, in eye of law, you are supposed to be master. And in our practice, when we consider our result like Aishwarya Rai, but it may turn like this anytime. So no tall claim, no rosy picture about result of your surgery. So communication and documentation, that is signature on consent form. And when you offer your this documentation, it becomes your communication of your documentation in court of law. So it is very famous maxim, that is volenti not fit injuria. It simply means one who accepts the risk cannot complain about it. So once you have explained everything to the patient, and after understanding everything, if patient has given consent for cesarean section with myomectomy or with tubal sterilization or cesarean section alone, then it could be a good defense in your favor. But at the same time, records are always at your rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standards demanded by law and ethics. And it should be easily acceptable whenever offered in the court, because a doctor is bound to produce record whenever asked by the court. And if he doesn't, then adverse inference might be drawn in the court. And it is very obvious.
Sorry
Good
to
record,
interrupt.
only 1 minute.
1
Okay.
minute. Yes, sir. Yes.
Good record is good defense, poor record is poor defense, and no record is no defense. And it is my experience during my medical legal practice, we doctors' friends are very poor as far as record keeping is concerned. As far as counseling and consent of cesarean section during era of this COVID-19, you have to explain everything about possibility of spread from patient to others, from others to patient, and all precautionary measures. And at the same time, you have to take history about traveling abroad by patient, by family members, by relatives, and possibility of contact with COVID patient, or possibility of with COVID patient by relative or family members also. And if patient turns out to be positive, then you are under obligation to inform appropriate authority as per government notification, and you have to transfer patient where COVID patient can be taken care of. You are dealing at the designated center, then you can very well deal with the situation accordingly. And you have to take an undertaking by patient in this detail. And at the end, you have to take that there is a possibility of further tests, involvements of other doctors, change in treatment protocol, and shifting of patient to higher centers also. And then after, you have to go for signature. And it is very obvious. It doesn't matter how many resources you have. If you do not know how to use them, then they will never be enough. So have some basic legal knowledge, and always obtain medical legal advice whenever you are in doubt. There is always a way. And in spite of this, our occupational and professional hazard, our journey to serve human and mankind is always on. And if you want to sleep like this, take tender care of your patient, good communication, proper documentation, and pray our Almighty God before going to sleep, and keep my visiting card below your pillow. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. And if you want to help somebody, then also you should take consent. See a very small video clip. This gentleman, after jogging, is relaxing, taking support of each car, and this gentleman, truck driver, see this, and he thinks that he is in help, so he goes to help him, and see how he helped. So, with regards, salute to the organizers, and thank you very much for patience hearing. And please do not assume, please ask if any question, if time and chairperson permits. Thank you very much.
Thank you, sir. So we don't have time for questions as such, but if you could please answer the questions in the Q&A box that are there. There are some questions for you.
I will do.
Thank you so much. And thank you, Alka Kriplani, madam. Thank you, Dr. Dinesh Kansal and Dr. Arun, sir. Sir, Dr. Arun, sir, can you please give a few concluding remarks? Dr. Arun Barua, so are you...
There was some There was some technical problem of his
I
joining.
think,
Dr.
Amrita, we are getting late.
Okay,
If it's not there,
I request Dr. Mandakini Madam to conclude the session.
No, I want to thank this Dr. Alka Kripalani for that excellent talk, and Dr. MC Patel. It was, wonderful, and all our delegates are giving so many questions, answer. I mean, they're really interested, and as Dr. Alka has mentioned very correctly that ICOG, the lecture series, certificate courses are becoming very popular because of the faculty which we have. So all you people are making it wonderful, and very, very thankful to all the faculties. Now we go ahead with other our other session. Aditi,
Shara to take over.
Yeah, please. So Rekha, please take over.
Shara.
Yes, ma'am. Good evening to all, and 3 cheers to ICOG for this highly successful course that we are running. Before wasting much time, let me have the privilege of introducing none other than Professor Naren Malhotra, sir. Can we have sir's CV on display, please?
Please
Support, can
display
we have the
yourself.
CV?
Please display yourself, Shela.
Just a second, ma'am.
Dr. Narendra is saying no. Just
Okay.
speak like that.
Okay. So I would like to say 2 lines for sir. Sir is famously known as Jack of all trades and master of all sciences. We know him as past President FOGSI, and he heads many national and international organizations. With folded hands, sir, we welcome you on board. Next, we have very, very popular Dr. Sheila Mane. Madam, it is sheer pleasure and pride to introduce you. We all know you as PPH Lady of India, our own very famous professor working in the field of PPH management and prevention. So, ma'am, we welcome you to chair this session. Now, Naren sir, may I kindly and humbly request you to please introduce Sir Arul Kumaran sir.
Very, very good evening to all of you. It's indeed a great pleasure to be here on this great ICOG course. Congratulations, Dr. Mandakini May. And it's a super pleasure to introduce to all of you a person who I have adored and who I have learned from when he was in Singapore and when he was in England. And not only me, my children have also, Dr. Niharika has also been a student. So Professor Sir Savaratnam Arul Kumaran, PhD, DSc, FRCS, FRCOG. He has been awarded as the knighthood in England, and he is the Professor Emeritus of OBGYN at St. George's, and where not. And he has been the past president of FIGO. And let me just add, he is a member of FOGSI, and we always treat him as an Indian and the closest of our friends in India. Sir, I remember after the Kanpur AICOG Congress, driving you in a second-hand ambassador car right up to Agra, and then staying with us in our house. You and it was those memories are still there. So I present to all of you, Sir Professor Savaratnam Arul Kumaran, to talk on
Narendra, on behalf of ICOG, I would like to, welcome, sir. I am very, very thankful that you are always there for all our ICOG courses. Sir, it is an honor and really privilege for the ICOG that you are there as our faculty, and you are treating the ICOG, like your own, the ICOG FOGSI organization, and keeping us motivated to do more and more courses. Sir, keep your blessings like this for always for the ICOG. So welcome, sir, and please deliver the lecture. Yeah.
Welcome, sir.
Thank you very much, Mandakini, and Sheila Mane, thank you, and Narendra, thank you very much for the kind introduction. So I know we are running behind time, so with your permission, Mandakini, we will start the presentation straight away.
Yes, sir.
So I'll go to share button, and then I hope it is the slides are seen. So I'm going to talk a little bit about maternal collapse, the incident causes and evaluation. The definition of collapse is loss of consciousness, and there are a number of reasons. We can subdivide them into inadequate cerebral perfusion, not enough blood goes to the brain, or inadequate oxygenation because of the respiratory issues, or abnormal cerebral electrical activity like eclampsia or epilepsy, or major brainstem dysfunction. This happens with metabolic disorders or drug intake. So we have to identify which one of the problems is causing the issue when somebody collapses. We have to also remember it can be a simple faint where they have a vasovagal attack. So if somebody is standing and their eyes are rolling and they are collapsing like a spring very slowly, it is most likely a simple faint. But if they're standing vertically and collapse into a horizontal position without consciousness, then it might be a catastrophic event like a pulmonary embolus or a myocardial infarction. And the initial treatment for all the causes of collapse is the same. We had to assess the state of consciousness, then we had to go for airway breathing circulation, except in a case of postpartum hemorrhage, it's very clear, the airway is clear, breathing is clear, we go as CABC, we attack the circulation, airway breathing circulation, and come back all over again. So this is the basic life support algorithm which we follow. We check the responsiveness, shake and shout, open the airway by head tilting and chin lift, and check breathing, because a simple thing like a obstruction with a denture or fluids can be aspirated or denture can be taken and the patient will be back to normal. So those are and they can kill somebody very quickly. So that's why the airway becomes quite important, followed by breathing. If there are no breathing, then you have to give 2 effective breaths and then assess the condition as to whether there is any circulation or not. If there is no circulation, we have to get with cardiac compression and get it into a fibrillatory state of the heart, then we can give 3 shocks. The reason we give 100 beats of compression is because when you compress the chest, it must move at least by a third distance in depth. And unlike a heart which is pumping, when you compress the heart, only about third cardiac output comes out. So you have to maximize the number of circulations. Whereas when you blow the air, breathing, it takes full account. So there is no problem at all in terms of, so we'll look at the common causes. The primary cerebral event can be eclamptic fit or epileptic fit, hypoglycemia, these are cerebral events, profound hypoxia, intracerebral bleed, cerebral infarction, anesthetic analgesic drugs. Here the history is quite important as well as the clinical examination, because if it is epilepsy, there will be a history. If it is eclampsia, there will be blood pressure and proteinuria. Hypoglycemia, patient might have been on insulin, and profound hypoxia might be due to asthma or some other condition. So history and clinical examination is quite vital to derive at a diagnosis. Cardiovascular event can be arrhythmia, myocardial infarction, and cardiomyopathy. And we know, again, myocardial infarction is getting commoner. Heart disease is the commonest cause of maternal death in the UK because mothers are elderly, obese, diabetic, and hypertensive. So we had to get the history and see whether they have a pulse and the blood pressure. And there are other issues, cardiovascular events with decreased cardiac output. This could be on the right side, like a massive pulmonary embolism. Then there is an absolute decrease in circulating volume, which is the left side, which is massive postpartum hemorrhage. So one of the two can give rise to problem, either blockage or not enough blood to go. And continuing on the same theme, there can be relative decrease in effective circulating volume, like faint, sepsis, anaphylaxis, amniotic fluid embolism. In this condition, there is no actual bleeding. So there is a relative decrease because of vasodilatation, and the meta-arteriolar sphincters are relaxed, and we had to really tackle the problem as together. So in drawing a diagram, we had to look at head to toe, and the top is eclampsia, intracranial hemorrhage, epilepsy, all that will come in, and also the possibility of drug intake. When it comes to the heart and lungs, pulmonary embolism, amniotic fluid embolism, and when it comes to drug, we can picture a possibility of magnesium sulfate overdose or illicit drugs. But hemorrhage is the most common in obstetrics. Postpartum hemorrhage, as mentioned earlier, but can be a rare condition like a hepatic rupture in preeclampsia or an abnormal aneurysm of the splenic artery. So we had to do a thorough examination, Bedside, you have to do a blood lactate if possible, blood sugar, and also send some blood investigation so you can find out. And sepsis is one of the major causes. And if it is a postpartum, then that is one of the things we have to remember very clearly. So hemorrhage should be always considered because it is the commonest cause in obstetrics. And we use an algorithm called hemostasis. And I won't go through that in detail, but it was explained earlier on about how we had to look at the medical issues of oxytocin, ergometrine, bimanual compression, prostaglandin, and tranexamic acid has come into use. And if that fails, on the right side is shock garment, tamponade, compression suture, interventional radiology if possible, and finally subtotal or total hysterectomy. Now, there are many causes of hemorrhage, so we had to come to a definitive diagnosis. Some of them are not revealed hemorrhages, so we have to be very careful that sometimes the blood can accumulate in the uterus as well. Using an early warning obstetrics score chart can help in these situations. And we must classify them, whether they are mild, moderate, or severe shock. Depends on the pre-hemoglobin before the early pregnancy. If they were anemic, then they are likely to go into shock much easier. And if they are low body weight, again, the blood volume depends on that, they can run into trouble. And one of the latest things which are using is shock index, which is the pulse divided by the systolic blood pressure. If it goes over 1, then it's a problem. Or rule of 30, that means they are lost more than 30% of blood loss. And we know that we had to, when we are resuscitating a patient with blood loss, we should really keep the pulse rate not to go beyond 30. So we had to, that means if it has gone from 80 to 120, that means we haven't given enough fluid. So the systolic blood pressure drops more than 30, then our infusion rate is not enough. So we had to do that. Now, cardiopulmonary arrest is very rare. It's extremely 1 in 30,000, but the chance of survival drops if you don't start resuscitating by 10% every minute. So if you don't resuscitate anybody by 5 minutes, 50% chance is lost. So we had to think about closed chest massage, which is the conventional treatment, perimortem cesarean section in rare conditions. Open cardiac massage is not a usual thing for us because it is done when there is a pericardial tamponade or thoracic injury or something of that sort. And finally, cardiopulmonary bypass, which is nowadays is becoming in postpartum cardiomyopathy. So we think about the basic life support. Advanced life support consists of giving catecholamines and additional drugs, bicarbonate, etc., if it is necessary. Now, we have to remember that in pregnancy, there is an increase in cardiac output by 20%, oxygen consumption by 20%, decrease in functional residual capacity of the lung, and decrease in lung compliance. So we have to keep that in mind when we are managing that. And systemic vascular resistance is decreased, as well as the uterine blood flow is increased, and there is physiological anemia and aortocaval compression. And we have to also remember that in labor, the situation becomes more acute because in the first stage, there is a further increase, and in the second stage, more. And third stage, the whole blood which has gone from the uterus is sustained in the systemic circulation. Now, this is a critical period for heart disease patients. They can go into heart failure, and also thromboembolic patients can run into trouble because of this hyperfibrinolytic state. So this diagram simply explains that if they are lying on a supine position, then the inferior vena cava and the aorta are compressed. There's a distended azoigus vein. Once you put them on the side, then the venous return is better and they will get better. So if there is no blood entering the heart to pump, then it's quite important to put them on the left lateral. You can use a wedge like a Cardiff wedge, or you can manually displace the uterus by pulling from the left side towards you till something is done. This is a human wedge, but now there is a recent college guidelines indicate that the cardiac compression cannot be performed on a wedge situation. So you have to put them horizontally on a supine, but pull the uterus to the left and give the cardiac compression. Now, perimortem cesarean section, just a few words about it. This was promoted by Katz. It says a pregnant woman suffering cardiopulmonary arrest, a perimortem section should be performed, and the benefits are high probability of a healthy normal infant, and also it's easier to do cardiopulmonary resuscitation. So it is done mainly for the purpose of saving the mother and should be done within 5 minutes with whatever is available. And I will skip open cardiac massage because that is special reserved for cardiac tamponade, thoracic injury, and so on. We'll go to the other causes. Pulmonary embolism was highlighted in the UK in one of the confidential inquiry because there was a high death rate, 31 deaths in 3 years. So we revised the guideline, and we knew that not only it occurs in the post-delivery, but it can be in the antenatal period. And the typical signs are chest pain, pleuritic pain of sudden onset, and sometimes it can be collapse and cyanosis. And there'll be signs in ECG, ventilation perfusion scan, or a spiral CT. And the commonest symptoms and signs should not be ignored: tachypnea, dyspnea, pleuritic pain. And the house officer should put an oxygen saturation meter in the finger, check the pulse, blood pressure, and make sure they diagnose the condition early. And ECG is an important thing to find out right ventricle strain. And you have to start them on heparin to prevent any further exacerbations, and start a VQ scan if possible. As you could see, there is a deficiency on the left apex. And if the patient is severely dyspneic, it might be a massive pulmonary embolus, overriding, called the saddle embolus, overriding the right and the left pulmonary artery. This is the pulmonary trunk. And this can be treated by immediate oxygen, IV fluids, heparin, large doses, followed by 24 hours. So if we can't do the VQ scan, if you're not very sure, then you can really anticoagulate them and do that. Now, if it is a massive saddle embolus, you can give 100 milligram IV alteplase, which is actually thrombolytic agent. And pulmonary embolectomy can be done percutaneous with catheters. So nowadays you can find a catheter, you can pass it in, and there are model catheters, new model catheters available, which springs into 6, and you can put the thrombolytic agent through the catheters itself. So you not only dislodge by perforating the clot and dislodging the clot, but dissolving them, because smaller clots are easier to dissolve. Then you maintain heparin. Amniotic fluid embolism, sudden collapse. The triad is hypotension, hypoxia, and coagulopathy. So you have to support their circulation, support their oxygenation by ventilation. And coagulopathy comes later on. And it is like an anaphylactic shock. So some people call it anaphylactic syndrome, shock of pregnancy. So acute hypoxia, there's a pulmonary artery pressure increase, and there can be severe DIC once they are delivered. So they have to be managed as symptomatic. Eclampsia, I won't go through in detail, but magnesium sulfate should be available. And the WHO is now looking at large doses intramuscularly because we are not managing the magnesium sulfate in the periphery quite well. But I'm sure in the hospital, we are all managing. Now, the main cause of maternal death in number of series is cerebral hemorrhage. So if the blood pressure goes to about 160, we have to make sure that we give antihypertensives to bring the blood pressure down. But we have to also remember there can be atypical eclampsia. Just because they didn't have blood pressure, it doesn't mean they don't have eclampsia. There's an atypical presentation if they present under 20 weeks or beyond 48 weeks or 48 hours postpartum. Septic shock should not be ignored. That is usually presents with 3 T's: tachypnea, tachycardia, and we can really try to identify. They will have signs of some retained product sometimes, usually postpartum endometritis. So we have to scan and find out whether there is any infected hematoma or retained tissue. But there can be non-obstetric causes, pyelonephritis, cholecystitis. So detailed investigations need to be done. And in pregnancy, the septic shock escalates very quickly and can be associated with disseminated intravascular coagulation, adult respiratory distress syndrome, profound hypotension, and renal failure. So a multidisciplinary care is quite important if they go into septic shock. Treatment after taking the blood culture, it should be broad spectrum antibiotics. We normally take metronidazole, cephalosporins, and gentamicin, so it covers the whole spectrum. Then we have to give 60 to 80 ml of fluid per kilogram body weight within the first 2 hours. And if necessary, circulate with inotropes and ventilatory support. And renal support will be necessary subsequently after she recovers, and we can manage them. So it's a multidisciplinary approach, which is quite important to save the life of the patient. And because of their physiology is changed from non-pregnant status, we had to get involved as obstetricians as well. we can't leave the work entirely to the intensive care people who can look at various things of coagulation, lung function, blood gases, but we must get involved as well. So there have been some few modifications in pregnancy. If you are going to intubate, then there should be a cuffed endotracheal tube, but bag and mask ventilation should be undertaken until intubation can be achieved. In the left lateral, they say in the absence of breathing despite a clear airway, compression should be commenced immediately, but this chest compression is better within the supine, but pulling the uterus to the left. And 2 wide bore cannula to establish circulation, which is 16 or 14 gauge cannula, so that you can transfuse enough fluids. And you must know about the drugs, which are same as non-pregnant, and energy which you give for shock is the same, which is 4 joules per kilogram calculation. And once you get a fibrillatory state, you can use a defibrillator and put the heart back together. So monitoring is key. And in the UK, we have all converted our temperature, pulse, respiratory chart to color charts like the MIOS charts, the modified early warning score chart, where we can plot blood pressure, heart rate, and we can have space for hemoglobin, etc. And we have to monitor the trend. Morning is I warn, so you can see the pulse rate going up, the blood pressure coming down systolic. So the shock index here is 1. And similarly, you monitor the hemoglobin urine output. That will also show things are deteriorating because of hemorrhage somewhere. And if it is hypertensive, it will show different signs. So in critical care, we had to define the current abnormal physiology, seek the causes, anticipate and prevent them if possible, and support the failing systems whilst healing process takes place. And it's important to have pastoral care to patients and relatives, like Dr. MC Patel said, not only before the procedure, but while we are treating, ongoing, we have to give counseling to the patients. So I'll just like to conclude by saying the recent Royal College guideline on maternal collapse is from December 2019, and I would encourage you to read that through going. It is endorsed by the NICE, so that is the one we follow. And thank you. So maternal collapse is rare, but we should be able to manage them and investigate. Clinical examination is key, and also doing some investigation. Thank you very much indeed.
Thank you so much, sir. We are indeed left speechless, but I'm sure Dr. Sheila Mane would be liking to say some words. Sheila, ma'am?
Yes. Yeah, I'm here. Yeah, I think we have to stop the share. Thank you, sir. I think such a vast topic, but you just elaborately and explain to everyone in a nutshell. I think it was very, very clear the message was, and you said that we should not be missing anything, because either it will be a near miss or we will miss. I think that was a clear message, sir. And I think most of the time what we face problems is either pulmonary embolism, which comes as a shock. And as you said that the cardiomyopathy is on the rise, because we do have elderly patients and those who come with atypical picture of either HELP or preeclampsia and later on land up with these problems. So that was a real good message, sir. And I think I know as it is a collapse, and sometimes it's very difficult to diagnose. And the amniotic fluid embolism, which is again a retrospective diagnosis, but one has to be really vigilant. So I think the basic as well as the advanced supportive technique and the course, everyone should be trained in the labor room. So then only it will be possible to save the mother to some extent, at least, even if she has collapsed. Thank you, sir, for your excellent talk.
Thank you very much, everybody. Thank you. Thank you, Narendra. Thank you, Mandakini. Thank you.
Thank you. And thank you, Madam Mandakini.
Thank you so much, Mandakini, ma'am. May we have some concluding remarks from your side, please?
No, I think we should go ahead. Sir has spoken after him. I can't, give any remarks. So please go ahead with the scientific program.
Thank you.
Thank you so much, ma'am, for kind permission. And with that, I would like to thank Naren Malhotra, sir, Sheila Mane, ma'am, and of course, greetings from all over India to Sir Sabaratnam. Thank you, sir. So moving ahead.
Thank you.
For our next session, we have the three chairpersons who have three things in common. All three are wonderful speakers, hardcore academicians, and loved by everyone. We have Dr. Basab Mukherjee sir, we have Ashish Mukhopadhyay sir, and we have Archana Verma ma'am to chair this session, and we welcome you wholeheartedly for our next session. So may we have the slides displayed, please?
Neha, be brief. Huh? We are already.
Shazia, please display.
Yeah, maybe, yeah.
Enable editing.
Yes, ma'am.
Please go to Dr. Basab Mukherjee's slides.
Who is displaying? Who is displaying?
Dr. Shazia, can you move the slides, please?
Yes, ma'am.
There is a block actually.
We need slides, Dr. Shazia.
Yes, ma'am. Just.
Or you can start talking, Sneha.
Yes.
So,
Basab.
yeah, please move ahead. First slide, Dr. Basab.
Yes.
Yes. So we have Dr. Basab Mukherjee, sir. He is Vice President-elect FOGSI 2021-22. And
move on because we are short of time. Just,
okay. Please move ahead.
One line introduction.
Ashish Mukhopadhyay, sir, teacher of teachers and queen of heart and queen of awareness, Dr. Archana Verma ma'am, Vice President, FOGSI 21-20. Can we have the slide for Peli, sir?
Yes.
Shazia,
Yes,
please move
yes,
the slide.
Yes, ma'am.
Peli, sirs.
Yes, ma'am. It's on.
No, Peli, sir, slide.
Dr. Piley is the fourth slide.
Hello, good evening.
So I would like to introduce sir in 2 lines, although the introduction will take more time.
Probably
Sir is
that actually, yeah.
Once you get the slides moving, why the slides not moving?
Yeah, we should not waste time on that. Shall we? After all, it's only 15 minutes for the talk.
Yes, sir. If Mandakini ma'am,
Yeah, please go ahead with the presentation. Piley sir, welcome.
Thank you.
Please stop sharing the slides.
Yes, sir.
Yes, sir. You can share your screen from your end.
ഇതാണ് അതല്ലേ നമ്മളുടെ പ്രസന്റേഷൻ അതല്ല എന്ന് തോന്നുന്നല്ലേ അല്ലല്ല അത് തന്നെ എടുത്തു അത് തന്നെ അതെടുത്തോളൂ മറ്റേതെടുത്ത സ്ലൈഡ് എന്തോ അത് വർക്ക് ചെയ്യുന്നില്ല അതുകൊണ്ടല്ല അതല്ല ഇതിൽ തന്നെ നിങ്ങളുടെ ഇതിൽ തന്നെയാണ് നമ്മുടെ ഈ മൗസിലെ ബാറ്ററി കൊള്ളില്ല അതാ കുഴപ്പം ചെയ്യോ താഴെ റൈറ്റ് സൈഡിലെ അല്ല റൈറ്റിൽ ആ സിമ്പിൾ ഇല്ലേ സ്ലൈഡ് ഷോയുടെ സിമ്പിൾ ഇല്ല റൈറ്റ് സൈഡിൽ ലോവർ റൈറ്റ് സൈഡിൽ താഴെ ആ സ്ലൈഡ് സിമ്പിൾ ഇല്ല
Dr. Amit, can you help? Can you guide?
റൈറ്റ് സൈഡിൽ സ്ലൈഡ് ഷോയുടെ സിമ്പിൾ ഇല്ലേ ആ പടത്തിന്റെ താഴെ അത് കാണിച്ചാൽ മതി ഇതിൽ കൊണ്ടുവരും ഇതില് ക്ലിക്ക് ചെയ്യും ഹലോ
Yes, sir. Any problem?
I'm audible?
Yeah, audible.
Yeah, thank you. I have been asked, thank you very much, first of all, Dr. Meg, Dr. Mitra, and all the chairpersons. Thank you very much for this opportunity. I have been asked this question. The adherent placenta, is surgical procedure different? Of course, Okay.
Sir, you require any help from our side?
No, I think they are trying to control.
Dr. Amit? See,
Yes, ma'am. I'll just stop. Sir, can you reshare it? I'm just stopping your screen sharing. Can you reshare it?
You want us to reshare?
Yes, sir. And share the PPT directly, sir. Please open the PPT first.
Yeah, it is open.
Okay. And share the PPT directly, sir.
Now it is opening here. Now it's opening here.
Yes, sir.
Yes.
Can I move?
Yes, sir.
Okay, the answer to the question is yes, it is different, but it depends on the type of adherent placenta. By adherent placenta, I assume that it's a morbidly adherent placenta that you want me to talk about.
Yes.
And of course, you know that there are 3 varieties of them: the accreta, the increta, and the percreta. These 3 are actually very different, even though internationally it is now accepted that we can club them together. They are not actually. Accreta and increta are not as bad as it sounds. So I would take them first. How to proceed in that case? I think we should have a clear idea about the extent of the placenta from our previous scan or MRI. And then put a vertical incision on the abdomen, vertical incision on the uterus without involving the placenta, and then deliver the fetus. Immediately sterilize the uterus and apply clamp on the aorta or the bilateral common iliac artery clamps. That will control the blood flow to the uterus. Now, after that, this is the clamp I am talking about. I will show you how to apply it. This is developed by us to clamp the common iliac arteries first, but then later we found that it's easier to clamp the aorta directly. This is the magnified part of that, where you can see that this clamp has got. This is even when it is closed, as you can see here, there's a gap between the 2 blades, so that the aorta walls will not get crushed or injured by use of this clamp. That's the point. So this is how we would show you to use this. You have the uterus sterilized, bowels are packed away, and over the lower lumbar vertebrae, you can actually see the aorta dividing into the 2 common iliac arteries, as you can see clearly over here. With a Babcock, without dissecting the peritoneum from in front of the aorta, you can just hold the lower end of the aorta with a Babcock, open the Babcock completely, gently lift up the aorta, and then bring that clamp to take full thickness of the aorta between the 2 blades of it. So you have got the clamp occluding the whole aorta. Remove the Babcock, and palpate that. You can feel that the common iliac arteries don't have any pulsation, which means that you have cut off the blood supply to the lower part of the body. So that way, once the blood supply is cut off, after applying the aorta clamp or the common iliac arteries, I'll show you with that another one. Deliver the placenta if it is possible. If it's only increta or increta, it may not easily come. But if it's only partially increta or accreta, it may come. So you try to remove that, and then you deal with the bleeding. Here is, I will show you another case, a case of a twin pregnancy, where, as you can see, a vertical incision on the abdominal wall. That's a uterine surface. Baby is not yet delivered. And we are putting a vertical incision on the fundus of the uterus away from the placenta. go all the way into the uterine cavity. You can see the two sacs emerging. And then once you have delivered the baby, now here we are applying the clamps onto the common iliac arteries, just like the same way we did over the aorta, putting a sliding knot over the infundibulopelvic ligament to take care of the blood flow coming through the ovarian branch. And now, once you have done that, we can remove the placenta from the uterine wall. In this case, it turned out to be only a partially incomplete placenta. But when you went to the lower part or the lower segment, as you can see here, as you can see here, the placenta is attached over that area. The placenta could be removed, but still there was a lot of bleeding. And so we went ahead with a hysterectomy for this case. That is pushing the bladder down. It was not involving the bladder. And so it was not a big issue to get that placenta delivered and the uterus hysterectomy done. But if it is a percrete placenta with bladder involvement, that is the problem. So in such cases, if it's a percrete placenta with bladder involvement, then we should have a different strategy. Severe bleeding can occur when the placenta is separated from the bladder. A strategy to control the blood flow to the pelvis is essential before starting the dissection. Because as you can see here, that's the bladder, and that is surface of the uterus, and you see the vascularity over there by Doppler. And then if you open such a case, as you can see here, these vessels from the bladder onto the placenta, which is totally outside here, onto the surface like that. These are the vessels which will start bleeding the moment we actually disturb those vessels. The whole place will get filled. Here, in this case, we had already applied the clamp, and that is why you don't see much bleeding. Or if you do a hysterectomy and see if the uterus was something like that, with the placenta which had come out over here up to here, and this is after a hysterectomy, subtotal hysterectomy, with the finger in the cervical canal, and that is the opening on the fundus, but this much of the placenta was outside, or as in this case, where the placenta was outside. In such cases, when you try to do the hysterectomy, there can be torrential bleeding unless you block the blood supply to the uterus. See here, the placenta after hysterectomy has been removed, and you see how thinned out it is. But this is a good case because placenta had not come out much. But if the placenta had come out, you will not see that much of the wall of the uterus over there. So in such cases, you should have a strategy to control the blood flow to the pelvis. That means the uterus. And the simple and first aid that we can do is aortic compression by applying your hand onto the lumbar area, onto the aorta. And then follow it up with a clamp, the one like the one I showed you. Or if you have the facilities for interventional radiology, have a balloon inserted, intravascular balloon inserted up to the aorta, and then inflate that. This needs, as all of you know, needs facilities for interventional radiology so that you can block it off. You may need theater facilities with this interventional radiology and all that, or you have to ship the patient to the radiology department, all messed up. So that is why we actually developed this simple method of applying the clamp onto the aorta and do it. If you know that there's a patient with percrete placenta that we are dealing with, what we do is we put a urinary catheter before the incision itself of the abdomen. Then you put a vertical incision on the abdomen, vertical incision on the uterus. You deliver the fetus and then apply the aorta or clamp, or the same clamp can be applied onto the two common iliac arteries. How we select whether to put on the aorta or the common iliac is, if it is an inadvertent diagnosis on the table with a transverse incision on the abdomen, you may not be able to access the aorta. So for such cases, we apply it on the common iliac arteries. Otherwise, we prefer to apply it on the lower end of the aorta. So that is what we do in these cases. The upper pedicles, after having applied the clamp and delivered the fetus, you release the uterus from the upper pedicles. They are clamped and ligated, And when you come to the border of the bladder with the placenta, that's the time the problem starts. So you get the Foley catheter bulb in the bladder, pull it up and see the outline of the bladder, and that is how we proceed further. What we do is, and what we recommend all over is, coagulate or cut the vessels running from over the bladder to the placenta, the percutaneous placenta, and try to keep the coagulum on the surface of the placenta intact so that it doesn't start to bleed from there, and get the bladder separated from the placenta until the lower border of the placenta is outlined. Once you have gone below that level of the placenta, thereafter you don't have to push the bladder further down, right down to the vagina or to the lower part of the cervix. This is the important thing I want to convey. And I know this is very controversial by many people, but we are convinced that you should not try to deliver the whole uterus up to the vagina. You keep the cervix back there. So then we clamp the uterine arteries after palpating for the ureter, which may be with the cannula, making it easier to palpate it, and go to a level below the level of the placenta, and then do not do total hysterectomy. Leave the stump of the cervix behind, get the clamps across the cervix and remove the uterus, and thereafter you reapply, religate if necessary all the stumps, and then remove it. So I'll show you with this video how we proceed in such a case. We are putting the urinary catheter, which we ourselves can do because of the cystoscope or even a hysteroscope, a vertical incision on the abdomen. Zoom out. Zoom out. Zoom out. A vertical incision on the abdomen. It may have to go above the umbilicus. We already know where the placental outline is, so we have put the vertical incision close to the fundus and delivering the baby. The baby is already delivered, and in this case we are going to apply the clamps on the common iliac arteries on both sides. On the right side it is relatively easier. On the left side the mesosigmoid may be an issue. The principle of application is the same. We pull up the common iliac artery after making sure the ureter is not close to it, lift it up, and then aorta clamp is the same clamp is applied. Here in this case, we are applying a tourniquet onto the infundibulopelvic ligament so that the blood supply from the aorta through the ovarian artery is taken care of. And here it is. We can then clamp and ligate the upper pedicles like the round ligament and the tube and the ovarian ligament until you reach the level of the uterine arteries. So that's the uterine artery clamp. Once you have put the clamps on both sides on the uterine arteries, then this is the important part of the dissection. As you can see, the placenta is outside. The placenta is already outside, and this is the peritoneal surface, peritoneum on top of the placenta. You separate it without disturbing this coagulum on the surface of the placenta. And once you have got the placenta separated like that, with the uterovesical fold of peritoneum separated like that, we can put the clamps on both sides to take care of the uterine arteries on both sides. Once you have gone below the level of the placenta, put clamps across onto the cervical stump, then cut and remove the uterus with the undisturbed placenta attached to it. Here you can see that's the whole area, the lower segment with the placenta still attached. That's the cervical stump over there. That's cervical stump. We are verifying that. And then put sutures, both stitch for the cervix, double ligate the pedicles and leave a drain so that she doesn't have a reactive hemorrhage after that. So now double check the stumps, leave a drain so that in case there is some reactivation of the bleeder, that can be that will be visible for us. Bladder base is the most treacherous part, and double check that there are no active bleeders at the bladder base. If there are any, you can either coagulate it or tie it, and then go ahead to close the abdomen. Of course, suppose there is only a local percreta or ingreta or accreta, can we do a local resection and avoid a hysterectomy is the question. Local resection and conservation of the uterus is possible provided it is not extensive percreta. Take care of the vessels running from the bladder dome to the placenta, and then what we recommend is incise above the upper border of that placenta, which is extruded. Deliver the fetus by displacing the placenta and breaking the membranes. Apply the aorta clamp. Separate the bladder, incise at the lower level of the protruded placenta, and remove the placenta with the membranes, and you can close the remaining healthy edges of the uterus, and that is what we would recommend. Suppose this is the placenta which has come out over here. What we recommend is, instead of putting the incision at the top like that, we can put a transverse incision over here. Placenta may still be underneath that. You rapidly go in, break the membrane, get the baby out, and then apply the aorta clamp. That will take care of the bleeders, and then go below the level of the extruded placenta over here and remove that placenta, and the intact uterine wall over here can be stitched back to the intact uterine wall over here, and you can retain the uterus. That's what we mean. That is a partial resection of the protruded placenta. It can be quite bloody, but if you apply the aorta clamp without much blood loss, then that will be okay for you. So this is what we would recommend for these cases. So in conclusion, friends, what I would suggest is surgery for a morbidly adherent placenta is different. Placenta accreta spectrum itself means a spectrum of disorders from minimal accreta to whole placenta, which is protruding outside like the totally percreta. And the problem here is it can be adherent to the bladder or bowel, or it can go laterally onto the parametrium with vessels and ureter. That can be a problem. So it's a big spectrum of the problem. The simple ones of ingreta or accreta really doesn't challenge you much, but if it's a percreta, that can be quite challenging. And unless you have something to control the blood flow to the uterus and to the placenta, like an aorta clamp, that bleeding can be horrible to the extent of death on the table. So we should have a pre-prepared attitude. We should diagnose these cases early and, of course, try to avoid a death on the table. Thank you very much. Thank you for your valuable time.
Thank you so much. Basab sir, may we hear from you, sir, also, please? So meanwhile,
Dr. Basa, please unmute yourself.
Yeah, I'll just join in a minute. If you can, some of the other chairpersons can just start the discussion.
Sorry, did you ask me anything, Basa?
No, sir. I'm just joining. I was in another one. Can another chairperson start the discussion? Is what I was.
Okay, Basa.
I'll just join in a minute. Sir.
Okay, so Ashish sir, may I request you to kindly take the discussion forward?
I think, Dr. Mitra, there was a question in the chat box.
Yes.
That how long to keep the aortic clamp? So that's
the aortic clamp can be kept easily up to 1 hour, 60 minutes. But we have had even cases where we extended it to more than 100 minutes, where there's more difficulties. So we can actually keep it longer than that. Well, the precaution we would recommend is, once you have finished your surgery, that is the bleeding part, then release it. Make sure there is no spasm of the vessel. It may not remain in spasm, but make sure it is gently massaged and the spasm is taken away. And postpartum period, you give them thromboprophylaxis. So we'll give low molecular weight heparin for such cases.
And sir, that partial resection, what you have showed, does it resemble the same, the triple P procedure? I mean,
triple P procedure, what is recommended from St. George's was you have the blood vessels reaching by dissecting and tying all the blood vessels likely to reach there. There, of course, they do recommend that. And Palacio from Argentina was the one maximum experience with this. He has done more than 400 cases of partial resection. For all of them, the issue here is whether we will be able to meticulously control all the bleeders unless you have something to stop the blood reaching there. So that is why triple P, or you can selectively isolate and close the bleeders, provided you clamp the aorta first, because otherwise the bleeding can be quite torrential. You see, the Westerners, when they talk about interventional radiology, they have the cell saver over there. Yes. They are prepared with massive blood transfusion, some 10, 15 people, specialists in the theater and all that. We cannot think of replicating such things in our setup. That is why we have evolved a practical, affordable method of tackling placenta percreta, because there is no scarcity for placenta accreta in our population as well, because C-section rates are so high.
Thank you, sir. I think because of the aortic clamp, the bleeding will be under control, and then it becomes...
We can even do cases without even blood transfusion sometimes.
Okay.
Professor Piley, Dr. Piley, I think Professor Arul Kumaran has congratulated you. He says it's a great lecture. Dr. Ishani Sachdeva has a question. Is there any role of a conservative management in placenta accreta syndrome? I think most of the talk was on that direction, role of conservative management in PS.
I mentioned it, Basab. Actually, if you want to conserve the uterus, probably what he meant was whether to leave the placenta alone, is it? That is another approach. When you say conservative, that is another option that people talk about. I am not a fan of that, because you leave any morbidly adherent placenta inside, you can end up, about 25% of them end up needing subsequent hysterectomy. It goes on for weeks and weeks. Sepsis is a big worry. So I am not for leaving the placenta behind, if that is what is meant by conservatism. There is an option like that. Leave the placenta undisturbed, like that. The other option of conservatism is conserve the uterus. That is, if it is a partial percreta, or if it's a partial accreta or increta, what I explained there was we can resect that part of the uterine wall and remove the placenta completely, reconstruct the uterus and leave her for future pregnancy. And Palacio is amazing. He has put down about 400 plus cases like that with his experience. And that includes all types of placenta, you should remember. Most of them are accreta or ingreta, but there were percreta also. Partially percreta also we can do that. Reconstruct the uterus, allow that uterus to continue to be allowed to have pregnancies later. And out of these 400 plus, he has reported that 110 or so became pregnant subsequently, and only 3 or 4 were subsequently placenta accreta. So in that case, this is quite a worthwhile. But personally, in our community here, if they have usually a previous cesarean scar, if that baby is alive and this baby also is salvageable, then most of them are agreeable to a hysterectomy rather than try their luck with all these percreta uterus being left behind.
So one small question from Dr. Veena J is in the periphery with minimal OT settings where aortic clamp is not available, what next can we do? So before aortic clamp, I think you did mention about other things. Yes. I think
Basab, what I would suggest is the most important thing is periphery should not deal with such patients.
Fair enough.
They should diagnose this early. And for that, our own recommendation, Kerala Federation has put down to the government, and the government has accepted it, that every woman with a previous cesarean scar should have a scan done at, say, 20 weeks, we may do it, but at least by 32 weeks to know where the placenta is. And if it is over the scar, there is no reason such patients should be looked after in a periphery. You cannot.
Absolutely.
The other question is, inadvertently, without knowing it, if you happen to open and find that it is a percreta placenta on the table, the safest thing to do is don't disturb it. Put stitches for the abdominal wall, pack her to a place where they can manage it. But in case you are meddle with it, then the next thing I would suggest is immediately put the assistant's hand onto the aorta. Stop the blood flow to that area. Try to get the bladder separated from whatever is possible and do a hysterectomy. Don't try to do a total hysterectomy. This is a message which I want to give to everybody. All the professors and teachers, please don't teach your students that a total hysterectomy is a must. It is not. The lower part of the cervix, which is not opened, can be left behind. It should be left behind, because attempts to do a total hysterectomy by dissecting the bladder away from that part of the uterus and the vagina is, I have found, as the most dangerous thing to do, because most difficult to tackle the bleeding at that point in the depth of the pelvis. So don't try to do that. So do a subtotal, but make sure the entire placenta is out and get out from there if possible.
Thank you, Dr. Paili. Pearls of wisdom coming out from you, and I'm sure all our attendees will be very beneficial. Dr. Sheila, shall we move on to our next speaker? Thank you, sir. Thank you for...
Thank you, sir. And thank you all.
Thank you, sir. Lady, sir, we have a lot to learn from legends like you. Thank you, sir. Thank you, Basab, sir. Moving ahead, we have our next speaker, Dr. Manju Puri, ma'am. She is Director, Professor, and Head of the Department of Obs and Gynae, Lady Harding Medical College. Ma'am, we welcome you, and we are eagerly waiting to listen from you.
Yeah, so good evening, everybody. Am I audible, and is my screen visible?
Not yet, Dr. Manju.
Not yet, ma'am.
Yeah, it's coming. I think it's on the way. It's just it's not yet visible. Can you stop and start again?
Yeah,
because
it's
just a black thing what we're seeing this side. I think Dr. Archana can take the discussion forward before this case.
It has got hung.
Yeah, that's why I think we can just do.
I think the screen has got hung. So shall I log out and then log in? I think that would be a better.
No, I think the organizers can do that. Dr. Sheila, can you just tell the organizers?
Yeah, ma'am, please.
Yes. Dr. Amit, please help.
Yeah, the technical team can stop you from sharing, and then
Dr. Manju, if you want, I have been able to join, so I can do my talk and while you log in and log out again, if you want.
Yeah, I'll just see in case I can go in, I'll go. Otherwise.
Yes, madam. Yeah.
Okay, Dr. Jaideep, maybe you can go ahead. I'll just sort out my own thing, right?
Meantime, if Dr. Paili is there, I want to know at what time we should wait for the delivery. What will be the best time to deliver when a patient is diagnosed as a ultrasonologically, antenatally, and with the corticosteroid?
Can Dr. Paili write in the chat box?
So Jaideep,
can we have a CV slide of Jaideep, sir?
I'll put it, Sheila.
Yes,
I have it. You can use this for the CV.
Welcome, Jaideep.
Manju ma'am, we are taking permission from you. Like to move ahead.
Absolutely.
I said welcome, Jaideep.
Thank you, madam.
Welcome, sir. To introduce, sir, he's Secretary General, Federation of Obs and Gynae Society of India, an all-rounder, doing all the work from the forefront, leading from every dimension. Here we have Dr. Jaideep Tank, sir, for his talk.
Can I share my screen, please?
Yeah, somebody has to stop.
Yes, sir, you can share your screen.
Right. I hope my slides are seen and I'm audible.
Not yet, Jaideep, I think.
Yes, sir. We are viewing sir's screen only.
Is it?
Yeah, this is my screen, okay, with the topic.
No, this is,
all right.
this is not Dr. Tank's.
No, yeah, no, this is my screen.
He started
with the topic. Yeah, I started. Okay. So thank you very much. Thank you very much to the chairperson of the ICOG, Dr. Mandakini Meg, our president, Dr. Alpesh Gandhi, the course conveners, very enthusiastic and dynamic Dr. Mitra Saxena and Surekha, and of course the ICOG office bearers, Arul Bhai, Parag, Dr. Lakshmi Shikhande. It is always such a pleasure and privilege to be in the same session as Dr. V.P. Paili sir and Dr. Manju Puri madam. So I must specially thank the organizers for placing me over here. And of course, to have a session chaired by Basab, Ashish, and Dr. Archana Verma is also quite a pleasure and a privilege. So again, thank you organizers for placing me there. I do apologize, I joined late. I was busy with another meeting, which I unfortunately could not push forward. So the topic that I'm going to speak on today is, do we need to revisit destructive operations? And to that, I would actually have to counter as to when did we actually leave destructive operations that we now have to revisit them. In my mind, destructive operations should actually be taught and be a part of everybody's armamentarium, because there will be very few circumstances, but there will be a given time when the knowledge of destructive operations will come to your rescue. In a sense, destructive operations are to be used when there is a mechanical difficulty during labor and a cesarean section for some reason is not possible. The cesarean section may not be possible because of the debilitated state of the woman. It may not be possible due to human resource constraints, non-availability of anesthetists, or it may sometimes not be possible because of infrastructure constraints. Whatever it may be, as I said, destructive operations are something which one has to keep in mind. I actually heard my first big lecture on destructive operations from this gentleman here, Dr. Glenn Mola from Papua New Guinea, when I had attended one of the AOFOG conferences. And I would like to give you a sense of when destructive operations should be done. There is no doubt at all, of course, that when you're talking about obstructed labor, if it is possible, a C-section should be your first choice. However, if you look at this country, that's Papua New Guinea, I had heard Dr. Glenn Mola many years back, and at that time, the entire country of PNG had maybe 2 or 3 qualified gynecologists. Now imagine an entire country with 2 or 3 qualified gynecologists, and look at what he wrote over here. There was this girl who was in prolonged labor. She came to the hospital. They did an emergency cesarean section. After a considerable delay, they lost the child. The girl developed a serious wound infection, survived, and was discharged. However, after 7 months, she was pregnant again. And because of that previous experience in the hospital, she said, I am certainly not going to go to the hospital. She has a rupture during a labor at home and dies. And no one in the hospital will learn that a long-term complication of cesarean section can be maternal death. So these are the kind of circumstances that we are talking about when we talk about the need for symphysiotomies and destructive operations. This is a paper from Papua New Guinea, and look at the cesarean section rate they have over there. It is 2% to 5%. I can tell you that this may not necessarily be because of a desire to reduce cesareans, but it could also be possible that it is simply because of infrastructure and human resource constraints. And look at their experience for symphysiotomy. A single college or a single tertiary hospital, symphysiotomy for 184 births. And if you look at Indian data similarly, you will find that there is a small place still for destructive operations. And this is a paper from PGIMR Chandigarh. And when they looked at their data, they found that they did need destructive operations over a very long period of time. As I said, it is very few and far between who need this procedure. But when you have the ability to do this procedure at some point in time, it will be very useful for you. I'm not saying I'm a massive expert on destructive operations. I have been delivering babies for decades now, and this has been my experience with destructive operations. I've had, when I was in training and when I was a lecturer in a medical college, I'd had one clidotomy, one inadvertent craniotomy, and I'll tell you about the case. I had the opportunity to do one symphysiotomy, and after I've come to private practice for around, I think it's been 20 years now that I'm in private practice, I've had one inadvertent clidotomy, one partially inadvertent viscerotomy, and I'll tell you why it was partially inadvertent, one decapitation, and I'm not really sure whether we should start considering multifetal embryo reduction, which I have a fairly large experience on, as a destructive operation. So let us start by talking about symphysiotomy. Initially, symphysiotomy was supposed to reduce the number of cesarean sections that were undertaken for mild to moderate cephalopelvic disproportion. Symphysiotomies were never meant for severe CPDs. Initially, Zarate from Latin America thought that the use of the procedure would actually result in the abolition of cesarean section. However, we know that there are urological and orthopedic complications which have ultimately led to symphysiotomy being regarded as an outdated operation. However, if you really look at it from a public health perspective, symphysiotomy seems to have a role in the management of CPD, being an example of appropriate technology. However, for most of us, and I will admit for me personally also, I would really hesitate very, very significantly before I would like to do a symphysiotomy, which explains why in maybe around 25 or 30 years of delivering babies, I've done only one so far. So when is a symphysiotomy indicated? It's indicated very infrequently, particularly when medical services and doctors are scarce, and the patient essentially comes to you with an obstructed labor. Now, when this happens, you have a choice between C-section, forceps or vacuum, and symphysiotomy, and what you ultimately decide to do depends on the descent of the fetal head, the degree of overlap of sutures. I mean, if you have more than a second degree overlap, it means that the CPD is already severe. Don't do a symphysiotomy. And of course, it depends on the dilatation of the cervix. You could consider doing a symphysiotomy at 5 centimeters in a multiparous or a 7 centimeters in primigravida. However, always remember that don't do it too early, because the diagnosis of disproportion now is no longer based only on partographic analysis, but also on the fact of whether the fetal head can pass through the pelvis or not. And it's really quite impossible to predict this. So again, this is a measure of last resort. Always remember that if you need an instrument after doing a symphysiotomy, don't use a forceps, because if you use a forceps, the soft tissue under the symphysis is completely unprotected and you may actually cause it to avulse. So again, symphysiotomy should not be a substitute for good judgment and careful case selection. Major complications may occur due to poor case selection, in particular the attempt to undergo operation for gross disproportion. This is for borderline cases in very, very specific situations where a cesarean section is simply not possible. So an emergency use can save the life of a fetus, but it should never be a planned option in a trial of labor. We never say that, all right, if the head gets stuck, I'm going to do a symphysiotomy. We don't do that. We do a cesarean section. Always consider the fact that if you're doing a VBAC, your symphysiotomy is really out of place. Symphysiotomies are not only helpful in vertex presentation and stuck heads, but they can also be helpful for breech, for bowel presentations, and shoulder dystocias. Of course, for shoulder dystocias, you have a relatively simpler option of doing a clitotomy. There are consequences to doing a symphysiotomy, because a symphysiotomy in essence is a permanent procedure. And when I say that it's permanent, I mean that the post-operative healing is by fibrous tissue. The cartilaginous tissue does not come back. And this fibrous tissue tends to soften and stretch in subsequent pregnancies and labor. So theoretically, a previous symphysiotomy is said to cure CPD, and the outcome of subsequent labor in women with a history of previous symphysiotomy shows an 87% vaginal delivery rate. I really like this sentence by Robert Bruce Salter, who says, decisions are more important than incisions. And in this particular instance, I cannot help but remark that it's probably the decision to do, or most importantly, not to do a symphysiotomy, that is to take or not to take the incision, which will decide the ultimate outcome. Perchance, if you need to do a symphysiotomy, as I said, I have done one and I have assisted in two. The critical things to do are put in a Foley's catheter, infiltrate local anesthesia, because remember you're working in a resource constrained area. Put your 2 fingers into the vagina like that and shift the urethra away like this. sweep it away and you will be able to identify the urethra because your Foley's catheter in is. Take a solid and put a stab incision at the junction of the upper third and middle third, and then start cutting inferiorly. Don't make the cut anteriorly first. Start cutting inferiorly till you start feeling your finger. Once you feel your finger, you have cut through the pubic symphysis. Turn the knife around without removing it and simply extend the incision till the top. Once the procedure is complete, the way to check is to put your thumb between the pubic symphysis. And if you can put your thumb, you have to understand that you have done an adequate enough job. Make sure that you don't abduct the legs. If you abduct the legs, you may result in a sacroiliac injury. Once the delivery has taken place, compress the symphysis with the thumb above the same position. Just compress it to express blood clots and promote hemostasis. Also explore that area paraurethral, particularly just near the catheter, very carefully. Post-operatively, nurse the patient on her side, continue the bladder drainage for some time. The patient may be discharged when her gait is confident and she is free of pain. And on discharge, she must be warned against undue physical activity for a period of 3 months and the need for definite delivery in a hospital in subsequent pregnancies. So again, not a procedure to be taken lightly or not a procedure without any permanent consequences. These are the possible complications, with hemorrhage being some of the most common. Most of the times, literature has shown that the hemorrhage which occurs after a symphysiotomy, unless you take an incision which is too deep, settles on its own simply by pressure. You could have a formation of an SUI and a bone infection. However, these are relatively rare. In fact, if you look at the data, it seems to actually suggest that perhaps we don't do enough symphysiotomies because, again, this Cochrane database review seems to suggest that symphysiotomy is extremely safe and very rarely results in pelvic instability. And if you look at this systemic review and meta-analysis from the British Journal, it actually says that there was no difference in key outcomes of maternal and perinatal mortality with symphysiotomy when compared with cesarean section. So my experience, I had to do a symphysiotomy in a patient who was transferred to the hospital where I was working as a senior lecturer, and it was an impacted breech with impending rupture transferred from another hospital. When I put the catheter in, there was a lot of hematuria. I didn't think that we had enough time. So I actually did a symphysiotomy on the spot. Luckily, the patient recovered very well. I put a catheter for around 5 days for that patient. The child was already dead by the time the patient came to the hospital, but we managed to get away without major morbidity. So as Winston Churchill has said, if you are going through hell, keep going. Don't freeze. And if it is required, then go ahead and do what is necessary. So if you're looking at destructive operations, you're typically looking at them in a situation where there is some kind of a hemodynamic compromise or even a sepsis. So one of the first things you need to do is first stabilize the patient, put in an RT for that patient to empty the stomach contents. And if you have access to anesthesia, please do give anesthesia to that patient. I would always prefer to give a regional rather than a general anesthesia for that patient. If you are suspecting rupture, then don't do the destructive operations, do a cesarean. Because if you do the destructive operation, you're actually increasing the chances that you will have a rupture. A fully dilated cervix is, of course, preferable. It is important to relook at the genital tract for trauma. I mean, if you have done a destructive operation, you'll realize that one of the most trickiest part is removing the fetus and making sure that the bony spicules don't damage the genital tract. That actually is a far more challenging part of the destructive operation compared to actually doing the destructive operation. Catheterize the patient, don't try to make her pass urine on her own, and make sure that that patient does not get PPH. And most importantly, sometimes in these very emergent situations, you may not have adequate time to counsel the patient, but at least later on, make sure that the patient is aware. So the craniotomy is the most commonly performed destructive operation. And in these typical situations, you have an IUFD and the fetus has got jammed into the pelvis and it is simply not coming out. And sometimes because the fetus is macerated, the forceps does not hold very well and you cannot use a vacuum. And so you have no option but to use an instrument like the Simpson's perforator. I remember that, I had actually hardly seen a craniotomy, but this was one of the instruments which I was always told to pick up in my MD Viva. I was always told, pick up Simpson's perforator, because if you pick up Simpson's perforator, there is very little the examiner can ask aage piche, and you'll make sure that you will stick to your topic. I don't know if you all had the same experience. So the Simpson's perforator and craniotomy still has a limited place, but the use of the cranioclast and craniotribe really has no place left in modern obstetrics at all. Of course, decompression of the hydrocephalic head, something which we really had to do earlier, is now extremely rare because of early diagnosis. But if you have to do this, you can consider actually doing it transabdominally under ultrasound guidance with a spinal needle. So this is that one inadvertent craniotomy that I actually had to do. What happened was that, again, this was a patient referred from another hospital. The fetus was severely macerated, and my junior who did the initial PV, actually, when she put her finger in, the finger went into the skull of the fetus. And that's how the craniotomy happened. So I didn't really use a perforator or anything. But once that craniotomy had happened, the problem really was how to get the bones out. They were already very soft, but it was still a bit of a challenge. And so what we did was that, we applied the vacuum cup on top of that. I know that vacuum doesn't work in a macerated fetus, but we just used it to protect that area so that the bony spicules would not hurt the genital tract. And we just left that forceps in place. We didn't do anything else. We made the patient bear down, and then the patient delivered. So this was, again, as I said, an inadvertent craniotomy. I've had one patient where I had to do a decapitation. I'm going to tell you about it. But this typically will happen when there's a transverse lie. A clitotomy can be sometimes quite useful when the shoulder dystocia is simply not responding to anything. And embryotomies, really speaking, are really not done anymore. So again, my experience in clitotomy, I had to do a clitotomy once when there was a shoulder dystocia. I can tell you, it's actually, we say that the clavicle is a soft bone and it's easy to fracture it, but it's really not. When you intentionally want to fracture it, it's actually very difficult to fracture the clavicle. You'll be surprised at how much force you need with the scissor to actually cut that clavicle. So remember, don't get scared. If you're going to use a scissor to cut the clavicle, you may really have to use a lot of force. Make sure you don't puncture the lungs, of course. But still, it does take a fair amount of force. It's really not as easy as it sounds. I remember when I was in my residency, one doctor had told me, what is there? Just put your finger inside and snap the clavicle like a twig. I said, Arey, if you have actually tried to fracture a clavicle, you will realize that it's not really that easy. We had one inadvertent clitotomy. That means the clavicle got fractured. I was trying to deliver a patient. There was shoulder dystocia, and while pulling, I think the one clavicle got fractured. So that was inadvertent. Again, my inadvertent viscerotomy was a macerated fetus with obstructed labor, and I was called to help. The doctor did a PV, and it was a transverse lie. And when they did a PV, the finger went right into the abdominal cavity and all the intestines started coming out. The doctor panicked and called me to help. And I said, that's all right. We'll just leave the fetus alone. The fetus then doubled up upon itself and delivered. We really didn't have to do anything much. It was just a bit of a panic. I've had to do one decapitation, and this was an interesting case. It was a fresh IUFD. The patient came in labor, and there was one cephalic and one breech. And then the first fetus came out and there was interlocking of twins. Now there was already an IUFD. She was already fully dilated. The option was to choose between a destructive operation and a cesarean. And over here, because it was an IUFD, I chose to do a decapitation, which was, again, to cut the neck with the scissor is, again, not a very easy thing to do. I had to do half of it with scissor and half of it with the scalpel. So again, remember, if you think that these destructive operations are easy, they really are not. The amount of force that is sometimes required is really quite significant. So in conclusion, obstructed labor due to CPD is, of course, now a rare phenomenon, and the late sequelae of neglected labor are hardly seen. As I said, however, sometimes you may have occasion to call upon skill or a ability to do these kind of operations. Again, you can see that with my limited experience on destructive operations, I still managed to deliver those fetuses in those circumstances. And if not practical experience, it is at least useful to know about destructive operations in theory. So I'll end by this slide from Octavio Paz, which says, wisdom lies neither in fixity nor in change, but in the dialectic between the two. And that dialectic between the two is what we constantly strive to achieve. So thank you very much again, Team ICOG, Sheila, Dr. Mitra, and Dr. Surekha for inviting me here. Thank you.
Thank you so much, sir. Your talk was indeed like a treat, a delicacy. So, for further comments, may I please request respected Archana Verma, ma'am?
And Dr. Jaideep, it was really a very wonderful talk. And nowadays in modern obstetrics, when we talk about the maternal mortality and the fetal mortality, we should be knowing destructive operation, though we need to learn that when the cesarean is to be done. And in our times, really, when we were doing even the senior residency, all the internal podalic versions, and after coming had breach in the breach, and that shoulder dystocia, 5.5 kg macrosomic babies, we used to do really. I have personally seen, I personally did so many destructive operations, but since 1990, I have never used and saw any destructive operation. It's out of modern obstetrics, I think, but we should know. And perforators, and of course, they look very dangerous. And if we do some complication, then we are gone. And the decapitated child, especially, and that mutilated child should not be shown to mother, because it creates a lot of psychological problem also. And nowadays we are facing so much of litigation also, and in the normal patient also, they always blame that doctor has done this and this. And even the psychovaginal fistulas, because of the obstructed labor, they were very, very common, and the blame used to come to the doctor only.
Yes. Madam, thank you very much. I'd just like to say two things very quickly. One, I would like to thank Manju Puri, madam, because I thought I'm going to be late for the talk, and madam very readily agreed to speak first. Luckily, I could make it in time. And the second is that case I told you about decapitation. We actually sutured the head back to the neck before showing it to the mother. Yeah, I think that's a very important thing you said, and we had done it at that time, but I forgot to mention it. So we took a few stitches on all the four sides, and we covered, the baby properly, like, and then we showed it to the mother that way. That's a very important point you made. Thank you.
Thank you so much, sir. And thank you so much, Archana, ma'am. So moving ahead, we are waiting desperately for Manju Puri, ma'am. Ma'am, are the slides, like, are you able to share them now?
Yeah, I'll share it now. Yeah. Is my screen visible now?
Yeah.
Yes, ma'am.
Yes, ma'am.
So after two wonderful talks by Dr. Peli and Dr. Jaideep Tank, I think I'm a bit nervous delivering my talk, and I hope that you find this talk also as useful as it was Dr. Jaideep and Dr. Peli's talk. So thank you, Dr. Mandakini, Dr. Parul, Dr. Parag, Mitra, and Surekha for inviting me to deliver this talk here. And I think without wasting time, I'll go ahead with the talk. Good evening, everyone, and good evening, chairpersons. I am going to talk on, I'll take you through some videos of second stage cesarean section. Dr. Pai had laid the foundation when he talked about Patvardhans. So I think I'm going to focus more on Patvardhans and take you through how to go about delivering, doing a Patvardhans. So when we look at deeply impacted head or a second stage cesarean section, the problems are that the lower segment is thinned out. There is risk of tear, broad ligament hematoma, bladder injury. The cervix is taken up, so there's a risk of cervical or vaginal incision if we go low down. The liquor is drained, so there is difficulty in extracting the baby. So it is basically the delivery of the baby, which we are worried about, how to get the baby out. So there is always a dilemma whether to deliver it as Keflek or as reverse breech or as shoulder first. So these are the three available options. The first is abdomino-vaginal method, that is a push technique. And Dr. Pai had very nicely shown that it is not that you push it with 2 fingers. It has to be a whole hand which should be pushing it, and you should try and flex the head while you're pushing it up. So this is the most commonly used method. Large number of people also use patvardhans, wherein, you know, when the arm pops out, when you have given the incision, so you deliver one arm, then you deliver the other arm, and then you deliver the baby. And the third is reverse breech extraction, which is usually done whenever we have a occipito-posterior presentation, where the shoulders are not so accessible. You know, you put your hand in and you bring out the foot, and that is how the babies would deliver. Now, abdomino-vaginal, I have already said, and Dr. Pai had already, you know, given a detail about it, but a little practical tips. When you do this, one is that you should anticipate that it's going to be difficult, especially when you have tried, it is a failed instrumental delivery. Then the head gets jammed in, you know, more impacted than what it would be. So have an assistant ready for pushing from below so that there is no chaos and no confusion. Give a Trenenberg tilt to the table. That really helps. Introduce your hand very gently between the lower uterine segment and the head. Then spread your fingers. That is, they are spread to break the vacuum. Or sometimes, you know, you put in your hand and then you bring it out and then again you can put in. And ask your assistant to push from below. So this is how you should go when you do it. Now, reverse breech extraction, I've already said that it is usually used when you have occipito-posterior position, when the back is posterior. Then the only alternative you have to delivering it as a vertex head would be to, you know, reach the foot and deliver it. Now, when we look at the, Cochrane database review, this is 2016 review, which compared different extraction methods at the time of cesarean section for outcomes of infant birth trauma, maternal complications, and long-term measures of infant and childhood morbidity. They concluded that there's limited evidence that reverse breech extraction may improve maternal and fetal outcomes, though there was no difference in the primary outcome of infant birth trauma, and further RCTs are needed to answer these questions. So this basically, compared head with breech. So taking you to the Patvardhan method, that is the shoulder first method. And very nicely, it was told by Dr. Pai that it was Patvardhan and Motashaw. And even Dr. Vikud said that we should call it Patvardhan and Motashaw. So this was way back when we were not even born. So that was the time when it was published in the Journal of Obs and Gynae India. So here, what do we do? So quite a number of times we remember when we were residents, that shoulder would pop out and we would get very worried. And even when we were doing transverse live and the shoulder would come, we would try and push it in and try to catch hold of the foot. So it is not like that. So if a shoulder comes out, let it come out. We first deliver that shoulder, then get the other shoulder out. And then we would hold the chest and give fundal pressure, the body comes out, and then the head would come out. So I'll just show you how it is. So this is how it is. We open it and the lower segment is all stretched. But remember, if you have to deliver the baby by Patvardhans, your incision has to be high. It has to be about 2 fingers below the reflection. So the lower segment is all stretched, so you will give an incision here. So here we've given incision. So then we assess which shoulder can come out. So we assess both the shoulders. So this, whichever shoulder is more accessible, we bring out that shoulder. The next is we bring out the other shoulder. So both the shoulders are out now. So now 2 fingers, that is the index and middle finger of both the hands, will go and hold the chest of the baby. And now the assistant is giving fundal pressure. So when you give fundal pressure, the baby comes out, it's like a piston. So the baby will be pushed out gently. The baby's body is very flexible. The baby comes out. And the head will then come out the way it had gone in. So you're not putting your hand in the lower uterine segment. So, and there are no tears usually, provided you have given a good incision and you have curved the ends of the incision upward. So this is a little video which I'm going to share with you. So this is one of our assistant professors who is now a professor. So wonderful surgeon. So this is what, V shot, and here she's opening it pretty high. That is what is important. So whenever you decide that you have to do it by, that means you have to take a call whether you're going to deliver it as vertex or are you going to deliver it as Patwardhan. So here she's given for Patwardhan, the incision has to be at the level of shoulders. So it has to be higher, and make sure that you curve the edges. So it should go upwards so that, they don't extend laterally and go into the broad ligament. So here she's trying to assess. So this shoulder seems to be more accessible. So she gently brings out. You have to be very gentle. You have to be very gentle. So you flex it and bring it out. You don't hook it out. So then you have to apply a little traction. You have to be careful so that you don't cause fracture of the humerus. So you hold it with a towel so that you have a grip, and then you put in your hand and try to reach the other shoulder. So here also see how nicely she's bringing that shoulder, more to the midline, and then she's gently easing out the arm. So you have to be very, very gentle. If you just pull it out, then there could be fracture of the humerus. So here it comes. Now, all good. So she's holding the baby with the help of fingers and thumb, and there the assistant is pushing the baby. The baby comes out, and once the baby comes out, see how nicely the head is come out. So this is what is Patwardhan's method. Now, the next is in case the back is posterior, right? So one way is that we can put in our hand and we can go ahead and get the foot. But sometimes when the back is lateral, so one of the arms might come out. So if it comes out, you don't have to push that arm in and then go in and bring out the foot. So let that arm come out. And so this is a modification of the Patwardhans. So here, available shoulder, whichever comes out is delivered. Then the hand is introduced towards the fundus. The foot is gripped and gently pulled out. And the breech is then delivered by fundal pressure, and the delivery of head is by lifting the baby. So if we look at this video now. So if you see here, so what comes out first is the arm. So this is what used to worry us a lot, when we were residents. So we would push it and so this stays out. So you take your hand in, you have more space now. So the foot comes. Now, the assistant can push it and the baby can pop out. So the baby comes out. And now, here, this is something wrong. We need not stretch it like this. It has to go upwards. So if you take it up, it will come out. So this is how the modified Patwardhans, this is what of the modifications. So this is our own study wherein long back, 2001 to 2002, wherein we did 50 patients with Patwardhans and 50 with vertex. The time taken with Patwardhans is much lesser. And although there were 2 lateral extensions, so these were the beginners who had given the incision, straight. So that is why you need to make it curvilinear so that your, it does not extend into the broad ligament. And rest all was okay. We did not have any injuries. So this is the routine method which we follow here to deliver babies. In a systematic review published in BGOG 2016, they compared, they evaluated various techniques of delivering the baby with a deeply impacted head at full dilatation in second stage. So they looked at uterine extension. They also looked at maternal and neonatal morbidities. So the results were that the risk of uterine incision extension, infection, mean blood loss, and operative time was significantly higher with the push technique compared with the reverse breech extraction. And there was inadequate evidence to support the Patwardhan method. So, there was not much experience, but in our own experience, Patwardhan method is really good. So one can, even if the back is interior, you can still go and bring out the, foot. You can hold the foot and bring it out. But then I think if the back is anterior, then either it is a, abdominopelvic method or it is a Patwardhans. So there could be another problem during cesarean, that is extension of the incision or adhesions. I think Dr. Pai had touched this also. Always exteriorize the uterus in case there is an extension. Bring the splayed muscle fibers together. Start holding from the area where, there is no tear. And then always place your fingers behind the broad ligament of the exteriorized uterus to repair the lateral extension to prevent injury to the bowel or to the ureter. For vertical extensions, pass a suture as low as possible, then lift that suture and then gently push the bladder with the help of a swab stick and go further down to the apex. And whenever there is a scar dehiscence, remember to freshen the margins nicely and then repair. a little video about dense adhesions. So you could face dense adhesions while you are opening. So this is a video by Dr. Aruna Nigam. She was an assistant professor with us. Now she's a professor at Hamdard, so Jamia Hospital, and good surgeon, very good surgeon. So here this was a patient who had previous one cesarean, and this was not a second stage cesarean, but because this is one of the common problems, so that is why. So this was a patient who had had whole of the uterus adherent to the anterior abdominal wall, and if you see, she's doing we would all do, and the aim is to try and open the peritoneum as high as possible. So she is kind of yeah. So once she had made this space, and now she saw that the muscles were all plastered, so she tried to get into a plane. She tried to open it up. So this is how we go layer wise. We try and separate, but this was of no avail. So she could not get into a place. Then again she tried. There's always a risk of bowel and bladder injury, so we try to go higher up. So again trying to open it. Remember that once this bleeding starts coming, that means you are entering the uterus. Normally you don't have this bleeding coming. So, this is one of the signs that you're getting into the myomectomy, when the patient starts bleeding. So initially you always try to go up because you want to open the peritoneum up, but here she was unable to go. So just trying to, find out space where she could go. So again, cutting it. And you can see all this blood coming out, meaning that we've already injured the myometrium. So again, nothing. So now the next thing is we try to go sideways, although we are not supposed to go between the peritoneum and the muscle, but there was no option. We had to, she had to go. So she started trying to get into the space. Then she decided to go a little lower down. So this is the actual space from where you can actually enter. So if you are doing it carefully layer by layer, so there should not be a problem. So, this is how we would do. This is somehow it was captured, but this is actual unplanned, approach. So once it is there, then, one would try and cut the muscles and, make more space. You have to reach an area where you can actually reach the peritoneum. So here, because the uterus is plastered in the midline, so there was no place at all. So then, one would try clamping the muscles, rectus muscles, and cut it. Yeah, so see, now this is the place from where she could get a place. Now this is the peritoneum. So the bladder is here. So because in the midline, it is all adherent. So after you get this, then you can go sideways and you can kind of open the space. So now she's putting a finger around, and this was the uterus, which was absolutely, ventry fixed. It was fixed to the anterior abdominal wall. And so then on the finger, you can always kind of, release this. And so this is where the space could be made. And then so the moral of the story is that here you can cut the tissues in the midline under the cover of your hand, and you will get a space lower down, below where the uterine scar is. So at the level of scar, it would be adherent. Otherwise, you will not be able to reach. So that is how it is. So, sorry. So the last slide is that the basic rules of dealing with difficult situations during cesarean section are anticipation. You should know that in what cases are you going to have problem. Preparedness. If you want to have a senior around, you should have a senior around. If you want to have a colleague around, please have them. Staying calm. Don't worry, don't get panic. It is the panic which creates most of the problems. Be gentle. When you do Patvardhans, you have to be very gentle. And after you finish the procedure, please reflect upon what you did, what was good about it, and what could have been improved. And then debriefing. Discuss it amongst your colleagues as to, what you did was correct, or could you have done any better. then, wait and absorb the lessons learned and share them with your peers. So this is my advice to all who practice obstetrics, that this is what should be your approach when you are faced with difficult situations. Thank you so much for patient hearing.
Thank you so much, ma'am. And we all know why you are a favorite teacher of all. So may we please have the pleasure of having Ashish sir that has joined. And sir, we would like to hear from you as well.
Sheila, before Ashish talks, just a quick comment. Manju, thank you very much. Did a presentation, superb videos. I would just like to point out to that the paper was published with Dr. Hello.
Yeah, we can hear you.
Yeah. Okay. The paper was published with Dr. Motasha, and I can tell this authentically because Dr. Patwardhan, who had described this method, happens to be my wife's grandfather. So, so this was one method which was taught to me by my mother-in-law, who's a senior obstetrician in the city of Pune, and just one small correction: the videos were beautiful. The second method is not modified Patwardhan. It is Patwardhan's method when the back is posterior, and then you very rightly shown all the steps, but then it is not called modified Patwardhan. It is just
Thanks for
Patwardhan when the
the
back is anterior and Patwardhan when the back is posterior. Thank you very much.
All right. Thank you so much. Yeah.
Thank you so much, sir. Ashish sir?
Can you hear me?
Yes,
Sorry,
sir.
I was held up in another emergency, obstetric emergency, of course. So I missed the video, the first part of the video, and the Patwardhan method, of which I wanted to see very badly, but I couldn't. Anyhow, whatever has to be said, I think Parag has beautifully summarized that. And we all know that these are the techniques which need obstetric, mastery. And I think that yes, this requires a special kind of attitude of calmness, quietness, and composure. And if you are in a hurry, he will not only spoil your own day, but also the future of the baby. So I think that the people like Dr. Manju Puri and all who are there, I think they have demonstrated nicely. And particularly the last part of the video, I saw the dissection of the adhesions in the repeat cesarean case when it was plastered to the anti-abdominal wall. That was very nice. And the most important point there we observed is that patience and going step-by-step approach. I think these are the two messages that we should pass to the audience. Thank you, Manju, very, very much. Thank you because of this excellent presentation. And kudos to your surgical skills. Thank you.
Thanks.
Thank you so much, sir. Thank you, Manju ma'am.
Stella, I just want to say one line for this whole session. This was a mesmerizing session. And I am very thankful to all the 563 people who are still hanging on. And I must confess that I was inhibited to put a topic like destructive operation. And I must congratulate Dr. Jaydeep to have done best justice to it, because this was a challenge. Thank you, Dr. Jaydeep, and thank you, Dr. Patel, and everybody. Next session, please.
Very well.
Dr. Meg, please.
Yes, ma'am.
No, Dr. Mandakini needs.
Yeah, I want to thank Jaydeep for taking such a, different topic, and I was very much, worried whether it will be taken or not. And you have really done a justice. But I want to also add to it that yesterday my talk was there on the local cesarean section, and where we do local, cesarean section in local anesthesia, there we get lot of destructive operation to be done. So we, myself, Dr. Pushpa Thurat, Dr. Sindhu Botre, we have a series of destructive operation done by ourselves because we had to do it. And second thing, after coming head in breach, in Kama Hospital, we have done it where there was CPD and the residents were struggling with the, hanging baby for 6 hours. And in that case, actually, Dr. Kamal Deshmukh was the HOD. I want to share this experience. And the vulva, everything was so much swollen, and everybody was thinking, and the unit head was Dr. Garud. She said, you go ahead with the cesarean section. So I said, no, madam, we can't do this because now it is very difficult. Let me think something. And what I did is all my practical experience of 30, 40 years, I asked the residents to pull the vulva. I took the second trocar of the empty this thing, laparoscopy. I burned the hole there, and in that hole I put a 6 number MTP cannula. And once the MTP cannula was in, and with the water, 2-3 times I sucked it, and the brain matter came out. And after the brain matter, immediately the head came out, where they were struggling for 6-2. And this case was presented in the JG hospital. Kamal Deshmukh madam was the HOD, and she has complimented me. Actually, it was an invention sort, because I had to use my whatever practical skills were there, I have used. So I just wanted to share that in such a stressful condition, whatever experience of surgery and this thing and instrument you have, you must use it. And this was a very unique case which I have to do. And we have saved the patient from the unnecessary cesarean section, and patient was very well after this destructive operation. So I wanted to share this, my experience. Thank you very much, all the speakers. Now let us move to the next session, please.
Thank you so much, ma'am. May we have the slides, please, for the next session? So while the slides are being displayed, Mandakini ma'am, the whole inbox is full with congratulations to you. It is indeed wonderful.
Shaila, you can go on introducing the moderators. Yes. Till then, Shaila. Shahjahan?
Yes, ma'am.
Shaila, please go ahead with the introducing the moderators.
Yes, ma'am. Slides are being displayed. Just 2 seconds more.
In fact, you may skip the introduction.
Okay, so naam to le sakti hu na, ma'am. So our beautiful and most wonderful moderator for today's panel discussion, Professor Surekha Tayade. Ma'am is unit head in JNMC Savangi Vardha, and then we have very dynamic Dr. Charmila madam. She is chairperson of clinical research committee, or she headed research committee of FOGSI in 2016-18. Very, very active, wonderful orator. So may I have the permission of introducing esteemed panelists also. So Dr. Richa Sharma, madam is professor in UCMS GTB Hospital Delhi, and she is FOGSI MTP committee chairperson. Next slide, please. Yes, Dr. Alka Bishnoi, she is senior consultant gynecologist from Bijnor, and that is my city, and I am so happy to see Bijnor on board. Welcome, ma'am. Next slide, please. Dr. Asha Jain, who does not know, ma'am, very, very active FOGSian. So, ma'am, please, next slide, please. Yes, Dr. Sarita Bhalerao, ma'am. Ma'am is a consultant in Breach Candy and Reliance HNS Cefi, Bhatia and Wadia Maternity Hospital, and Vice President MOGS 2020-2021. Dr. Pramila Malik, we have she has done her MBBS and MD from AIMS, and immediate past President Gurgaon Obstetrics Society, very active one. Yes. Next we have Professor Dr. Geeta Madam. She is Professor Government NSCB Medical College Jabalpur, dedicated teacher and great learner. Next we have Dr. Jagriti Yogesh Kumar Desai. Ma'am is President SOGS 2021-2022, great laparoscopist, obstetrician and gynecologist. Next we have Dr. T. Chitra Madam. She is additional Professor JIPMER. We welcome all the esteemed panelists to have a wonderful discussion. Over to Surekha ma'am and Charmila ma'am.
Thank you, Sheila. It was very sweet of you, as usual. I'd like to thank Dr. Mandakini Meg madam, Dr. Mitra Saxena madam, as well as Dr. Surekha for the opportunity. I would like to say that I am a student of Dr. Mandakini Meg madam from Kama Hospital.
Yeah.
And all the innovations, whatever we have learned, is the basis of that Kama Hospital. And I'll always remember madam for that, because I was a student in her unit in Kama. And
extensive work in vaginal hysterectomy, abdominal ectopics. The maximum ectopics used to come in my unit.
Yes.
That is a great experience. Thank you.
And she used to give us so much of clinical work to do, and that no other chief had done up to that time for us. Thank you so much for that. And the main thing, we have been talking about so many cases from evening. So it will be actually a recap of what has been done, because what we have seen is we read guidelines, we read papers, we try to change a method of management in obstetrics, but we always go back to our basics, what our teachers taught us as postgraduates. Very difficult to change our mindset once we have learned something. And that's what we will be discussing on certain points in cesarean section, because the talks have been done extensively by such great speakers. So I would like to actually, the panelists are all from different parts of the country. So when we have an opinion from each one of us, because whatever the guidelines say, what our experience helps us only will be in the crucial time. You don't remember your guidelines when you're managing a difficult case. It's what you usually have done before, and that comes handy. So we'd like to know the opinion of the panelists so that we come to a consensus of what is working for us in our country. So I'd like to just share my screen now. Sureka will be doing the next part of it. I'll be doing the entry as well as a extraction part, the troubleshooting in the cesarean section. So the first, I would like to thank all the esteemed panelists who have joined: Dr. Richa Sharma, Dr. Alka, Dr. Asha Jain, Dr. Sarita, Dr. Promila, Dr. Geeta, Dr. Jagruti, and Dr. Chitra. So you can actually debate among yourself, not among yourself, within yourself, and tell us what is right and what is wrong. So Dr. Richa Sharma, Dr. Arul sir gave such a beautiful talk on Joel Cohen. So what do you think is right? Abdominal insertion and entry for cesarean. Do you do a Joel Cohen or fan and steel is okay for you? Dr. Richa is there?
Dr. Charmila, Dr. Richa had to go for an emergency. Okay. A patient, some VIP collapsed.
Okay,
so maybe she may join later, but I think somebody else can take that.
Okay. Chitra?
Yes, ma'am.
What do you think is right? Jipmar, what do you do? Joel Cohen or fan and steel?
Ma'am, we before used to do joint co-incision. Now, because it's a PG institution, we are training fan and steel, ma'am. Because it's a
why did you change yourself from Joel Cohen to fan and steel?
Ma'am, it is seen that most of the patient had more post-operative pain in the joint co-incision. Though they did one study, they're told like in our Jipper itself only when they compared Fanistel with the joint incision, patient post-operative pain was more in joint incision than Fanistel, but it was not significant. Since it is a training institute, they told better to teach them Fanistel incision. So we are back to the Fanistel incision.
So how many years you're doing fan and steel now?
Ma'am.
Are you doing a comparison between the previous patients and this group to find out whether the pain has gone down?
No, we did not do comparison, madam.
Okay.
We do the only when what you call randomized RCT we try to do, but in between when we found that this patient had more pain, so we stopped it.
You stopped the study.
Yeah.
Anybody else in the panel has got an agreement or disagreement with what Chitra says? Jagruti, Dr. Jagruti?
Yeah, we usually use a financial incision only. And our experience, my experience is best with financial incision.
Okay, two now. The next panelist, two to 0 now. Next. Sarita? Sarita, please unmute yourself, Sarita.
Yeah. So I also agree that we've been doing fan and steel always, and I'm very comfortable with doing the fan and steel incision.
Okay, Pramila?
I am using Joel Cohen.
Okay, so 3:1. Asha?
Ma'am, I do fan and steel because, on the sides, the vessels are there. And when you do a Joel Cohen, invariably they start bleeding. So it's better off when you can visualize them and cauterize them and then cut through. So I'm more comfortable with a fan and steel.
Yeah. Okay, Dr. Geeta, you'll have the final say now. You will give us a conclusion.
I am very comfortable with the Joel Cohen, and I am in disagreement with Dr. Asha because I feel the Joel Cohen don't bleed at the angles.
Okay, so it's actually 4:2. So we'll ask Mitra Madam at the end. Madam, you will give the conclusion. The debate is going on, so it's 4:2. But actually, what the
technically, I mean, all the points are in favor of Joel Cohen. My only take is that fan and steel we've been comfortable and it's very aesthetically pretty.
Okay.
It's
okay.
very
Perfect. Good for our patients who wears a low hip sari. Okay,
Yeah.
fine. So the Joel
May I
Cohen
get say also?
you will do it next. You will do it next.
Okay.
The moderator is not supposed to ask questions to the other moderator. Okay. So the Joel Cohen technique, when you compare it with fan and steel, is actually supposed to be better. It actually causes a decreased blood loss, a shorter operative time, a reduced post-operative analgesic requirement. That means the pain, they say, is much lesser in a Joel Cohen technique. But I think Chitra should do a study along with other people and tell us like whether what is right, because as many of us are trained in fan and steel, we are very comfortable with fan and steel. But what we do is, I'll tell you, like, and Parag is there to attest. Actually, we combine both as usual. We take all the Western countries together. That is, we open sharply and then make it all blunt, and the incision will be a fan and steel. But the opening will be a Joel Cohen, and you'll finish with something else. That masala which you are used to in India, we do it for our incisions.
Madam, our study was dropped mainly because of this, ma'am. They were never following it. So they give the they used to follow. So that's why we stopped the study.
Because in a fan and steel, it's supposed to be open sharply.
Yeah,
but
everything
we open sharply, but we go bluntly after that. We go like a Narasimha Avadaram. That's what I've seen. So at heart of heart, we know that we go with a blunt dissection, but we open sharply. But we'll put the incision like a fan and steel because, as Mitra Madam said, we wanted a cosmetic effect. So we do that. So that is one consensus. So Dr. Alka Madam is there? She's there? Dr. Alka? She's not there. Okay, can I ask Dr. Pramila to take this question? Suppose she's a morbidly obese. Would you like a vertical or a transverse incision? Abdominal incision.
I'll go with the transverse incision only.
Okay.
And, ideally speaking, it should not be on the flap of the fat should not overlap the incision because it will delay the healing.
Okay, so it will be like a higher transverse butt.
Very morbidly obese, the recommendation is even you can go a supraumbilical.
No, we are not talking about any recommendation. We are talking about what we are doing in our practice, and we are crossing our hearts and saying the truth now. Not what the guidelines say.
Should not lie below that flap of the.
Okay, fine, perfect. That's what most of us do. Anybody goes for a vertical incision for a morbidly obese patient? No. Any panelists? No. Okay, all of them have agreed. This panel I don't like. No, you should have somebody should have decided.
It's easy to do. When you remove the flap up, you get a very nice plain just for pubic symphysis, and the fat is also very less. It's just like a primary cesarean section. You won't even see that there is a big fat layer in that area.
So what are you disagreeing with Pramila on here? You agreeing with her or disagreeing with her?
No, agree.
She's saying that she is not taking it up. She's saying that she's taking it beneath the flap. She's not saying it's up.
The placement of the incision is below the flap.
No.
Pramila will take it on the flap.
Below the flap. It should not be below the flap.
Okay.
That's what
because it will delay the healing because it will be this thing that flap will hamper the healing.
Why don't you put below the flap and put this thing belt for later on abdominal belt? You can lift the pan is up. That can also help her.
No, she cannot. It can't be lifted permanently.
Right. It's already a gone case there. Okay. So in a morbidly obese patient, as the panelist said, a transverse incision is considered the best. Even though traditionally vertical incisions have been recommended, saying that there's an increased infection rate if an infrapanicular low transverse incision was obtained, but actually that's not true. The vertical incisions are associated with more of intraoperative bleeding, increased risk of a classical cesarean hysterotomy, the increased risk of wound complications, and a greater postoperative respiratory compromise. So actually, the theoretical concern of having a more infection rate with transverse incisions have not been proved in many studies. So you can go ahead with your low transverse incision. Asha, regarding the bladder flap, what is your take on that?
I create a bladder flap.
Anybody
by sharp
else?
dissection.
Dissection.
By sharp
dissection. Perfect. Pramila is disagreeing already.
No, I don't create a bladder flap.
Chitra?
Ma'am, I agree. I create a bladder flap in all cesarean section.
Okay. Jagruti?
Yes, I also open up the bladder peritoneum with a sharp scissor and just retract it down. Don't dissect it.
Sarita?
Only if the bladder is pulled up because of the adhesions. Only then I create a flap to push it down. Otherwise, if the bladder is low below and you have got enough space to make the implant incisions, you don't need to facet the bladder flap.
Okay. Sarita, your opinion on that?
So I open the peritoneum with a scissor and then push down either with a swab-on holder or with
so you
my
create
finger.
a bladder flap. Okay.
Yeah, yeah.
Geeta?
Dr. Charmila, what I would like to add is that if you don't create a bladder flap, once the uterus has retracted, many patients have opened, somebody else has operated, they've just stitched the bladder to the lower uterine segment. So it is always wiser to separate it a bit so that, you can hold it away.
Okay, perfect. Just one opinion from Sarita because she wanted to say something. Sarita?
No, I didn't want to. I said that
I create a bladder flap. Geeta, Dr. Geeta has to say something.
I too create a bladder flap because once the lower segment is stretched out, the lower segment may seem to be very long. Once the BT is out, sometimes you find just a bladder peeping over the lower edge. So I always find it wiser to create a flap.
Is Arul sir there? Because everybody is disagreeing with him now. Arul sir is there? No. Madam, you have to make a note of it, Mitra madam, because most of the panelists are going against the guidelines.
Yes.
And they're finding a better outcome actually. So when we collect the data, I think we can present that all this is necessary in our group of patients. That's what I think we need to do. Because what the guideline says is there's insufficient evidence to recommend for or against the routine creation of a bladder flap prior to making the uterine incision. Evidence suggests that if we create a bladder flap, it can lead on to increased postoperative urinary retention, a worsened postoperative urinary symptom, and increased incision to delivery time. But randomized controlled trials and meta-analysis have shown no difference in bladder injury with or without development of the bladder flap. But there was a 2013 systematic review which said routine creation is discouraged, but as most of the panelists said, suppose it's stretched out and there's a failure of descent, and there's a theoretical risk of the bladder being higher on the lower uterine segment, the surgeon is justified in creating a bladder flap before going ahead with a uterine incision. So we have justifications to create a bladder flap in certain groups of patients where the lower segment is thinned out and stretched. So Dr. Sarita, when do you go for, do you routinely prefer a transverse incision or you do a vertical incision, low vertical?
Lower segment, transverse incision always, unless it's a preterm cesarean, lower segment is not formed, then rarely have I gone for a vertical, or if I feel it may need to be extended into the upper segment, but otherwise always a lower segment transverse incision.
I think most of the panelists will agree on that. Anybody wants to disagree with Sarita there? No. I think all of us
I've done one vertical in a case of cancer cervix.
Okay. That is another indication, right? Perfect. Yeah. So when will you deliberately extend your incision, Dr. Sarita? What are the indications you will do it? Already there's been a discussion in the talks, but I'll just like you to elaborate.
Yeah. So, sometimes if it's not possible to deliver with a large baby, or if it's a transverse lie, it's a difficult lie, or there's oligohydramnios, or then high floating head, sometimes there may be difficulty in delivery, then we may have to extend the horizontal incision laterally.
Yes. And always you have to mention in your case notes that you've done this because that's going to cause an increased risk of uterine rupture in a subsequent pregnancies. And most of them are all tourists. They go from one doctor to the other. Asha, please keep your phone down.
Sorry.
Okay. So most of the patients travel from one zone to the other also nowadays, but not now in COVID. So they'll be landing with another doctor who will not even know what happened in the previous cesarean. So please make a note in your notes that you extended the incision for such a reason, so that they know that there's a higher risk of rupture in a next pregnancy if she goes for a VBAC or something like that. So Dr. Pramila, would you like to extend the hysterotomy blunt or sharp dissection?
If the lower segment is well formed, and it is not thin or over distended, I would like to do a blunt dissection, and the direction of extension should be from cephalocaudal, not like laterally.
Yes,
it's very important. The direction has to be from cephalocaudal. Because like that, it will extend on the lateral and include the uterine vessels.
Yeah, like this.
If the lower uterine segment is not formed, well formed, like in a very premature fetus, or if it is very papery thin because of the previous cesarean or because of the adhesions, then I would like to do with a sharp dissection, keeping the finger to protect the fetus inside and extend the incision in an upward direction. Yes. Smiley. So that it doesn't extend laterally when you are delivering the fetus.
All the postgraduates will remember that smiley which Dr. Pai put up, no? It was so clear.
And the direction of this has to be from cephalocaudal, not lateral.
Lateral, yeah, perfect. So that is what the NICE guidelines as well as the American College says. Always extend your incision if you want bluntly in the cephalad caudate direction, as Dr. Pramila put it so clearly, because there are significantly fewer extensions when you do it bluntly. There's a lesser chance of injury to the uterine vessels, and the ladies also experience a lesser blood loss compared to
lesser
a sharp
time,
dissection.
lesser blood loss, and lesser risk of extension.
Yes, yeah, perfect. So I think all of you agree with that.
Yeah.
Okay. Dr. Geeta, the question to you, like there were so many talks about the methods to assist delivery, or the vacuum, the forceps, tocolysis. You think anything works?
No, I have, honestly speaking, I've never needed tocolysis to deliver a fetus. Okay. I think once or twice, probably when the uterus is just trapped on the baby, then probably I just would ask the anesthetist to just deepen the plane of anesthesia if the patient is in general anesthesia, which in such cases usually happens to be because it's a neglected labor. Okay. And once I remember using a nitroglycerine patch, I don't know exactly, but I guess it is because again of a trapped fetus. But no, I have never used tocolysis routinely. No.
Vacuum forceps?
Yes.
Instruments?
Yes. Instruments.
What are you familiar with, vacuum or forceps? Which you think is more comfortable for you?
Vacuum, I guess, is quite.
Sometimes you use, very rarely use.
Yeah.
Asha, what do you
I use vacuum.
Assistance?
I use vacuum.
Romila?
In a free floating head, but if the fetus is not premature, if it is a term fetus, in a premature fetus, I prefer to deliver with the internal potalic version. Okay. But if it is a term fetus with a free floating head, vacuum is very comfortable.
Sarita?
Yeah, so I'm a big fan of forceps.
Yeah,
and I find that the moment I put the forceps and I steady the head, I don't need someone to push nothing. And it's a very easy delivery and I guide the baby out. So I'm a big fan of the outlet forceps at cesarean.
Okay. Jagruti?
Yeah, I have never used tocolysis to facilitate birth, but I have routinely used vacuum. And I'm fond of Manju's delivery.
Yes. Okay, so 2 vacuums, 1 forceps, 1 sometimes, and the other is not Chitra also accepted a vacuum. Okay.
No, madam, forceps. Always
okay.
forceps.
So 2 forceps, 2 vacuum, and 1 sometimes, and the other person, what did you say?
Me.
Madam, no, madam, you and Sureka are not allowed to answer. Okay. So it's actually methods to assist delivery, as all the panelists said. Tocolysis may be used, but nothing works actually. This study, I think madam also put up, Dr. Manju madam also. So using vacuum forceps for this manual extraction, they did a randomized trial, and actually 2 randomized trials, and 128 women were identified. They did not find any difference in the birth trauma. Either do you do by instruments or do a manual extraction, it does not matter in an elective cesarean. There's no difference in as a fall in hemoglobin or a uterine incision extension. So, and there's nothing to say that tocolysis works, as the panelist said. And instruments to facilitate it, infant birth, it's not advocated, but if you're comfortable with, you can proceed, because there's no change in the birth trauma or any other problems which can happen in both the groups. This will be the last. Dr. Jagruti Desai.
Yes.
Actually, there was so much of discussion in the last talk on this reverse breech extraction or a head push. Which are you comfortable with for a deeply impacted head? Dr. Jagruti?
Yeah, for a deeply impacted head, it is better to anticipate what difficulty you are going to encounter.
No, so what will you do? What will you do when it happens?
So when I open up the uterus and when I find that the head is deeply impacted, I immediately pass my hand towards the fundus, catch hold of the fetal legs, and deliver my
so you like a reverse breech extraction. Reverse breech. Pramila, what is your take on that?
I use Patwardhan.
Chitra?
But if it is back is I deliver with
reverse breech.
Ma'am, Patwardhan, most commonly used, but most of the time we try to ask the assistant to push from below. If at all we know deeply impacted heads are taking for section, before itself only we'll try to push it above, and it will help us to break the vacuum.
Okay. So you think it works, pushing from below?
Yeah, madam. Before, if we're thinking we're taking up, we try to push it from below.
Jipmer study is there?
We have not studied, but it's really helped us, madam. It will be easy extraction.
Okay. Sarita?
No, I go for the head. I will increase my height, stand up on a stool, put my hand in, go deep down, disinfect the head and deliver from the head.
You've never had a problem?
Not really. I feel if once you go for the head, it's, it is better, because sometimes you can get into trouble when you try to remove the breech and maybe the hand comes out, and it can become a difficult delivery, very difficult delivery. So I think if you go for the head and disinfect the head, the rest goes through.
Geeta?
I think I don't have a standard. First is, of course, I'll go for the head. I won't put too much of effort. If it's not coming out, then I go for the breech. And sometimes when I find that the shoulders are just popping out, then Patvardhans is my choice. I mean, whatever suits particular.
You'll choose on the table. Most of us do.
Mitra, I have never done like pushing from down below and then going for this surgery. No, not done.
My personal take is that whenever we have to push from below, I do it myself. I introduce my whole hand and hold the head, rotate it back and push it up. And so I make sure it really goes up. Only
it really helps.
Like a modified Zavanelli. It's a modified Zavanelli.
Ma'am, it won't be out, madam.
No, just rotating and sending, bringing it in.
If I have to do Patvardhan, then that don't touch from below.
Never.
Incision higher up. If you have not placed the incision higher up, you will not be able to do Patvardhan. So you have to plan everything before.
Yes, agreed, madam, absolutely.
In a second stage cesarean, still, even if you don't have to do Patvardhan, you should place the incision very high up.
Or it should be open corporexis.
May incise the vagina or the cervix.
Yes. Very careful. Put always a higher incision when you're going for a impacted.
Go the UV fold, because the core segment is pushed up.
Okay. Surekha, you want to say something?
Thank you. The moderator gets to speak.
Yes. One answer. Only one.
Never push from below. That is our dictum in our department. Either
so we will have a data collection from Varda, and you will have from JIPMER. Two great
and
institutions.
Also, last 20 years in MGIMS Sevagram also, we never did it from below, because we had a lot of cases where pushing from below was a problem. We always go for either the Patvardhan or the reverse breech, and that has given us a good outcome.
Okay.
I think I also have never pushed from below, I think.
Okay.
So
I go with what Sarita say, be a bit higher and put your hand in and disimpact and take it out.
Bring it up.
Most of the time that works. If it doesn't work, then it has to be the reverse breech.
Reverse breech. Or then finally the Patvardhan.
Okay.
Yeah.
So this is what the guidelines say, that reverse breech is much better compared to taking it out from, like as the panelists said, going from above. The head pushing the head and then taking out the baby is associated with more problems as secondary outcomes rather than the primary outcome of birth trauma. So you will have more chance of endometritis, extension of uterine incision, teen blood loss is more, and the NICU admissions are more when you go with the other this thing of head push. But when you go for a reverse breech, you will have a decrease in all these outcomes. And the operation duration was also significantly shorter for reverse breech extraction, and that may correspond to the ease of delivery and the amount of tissue trauma and the significantly less blood loss. So reverse breech is the one which the guidelines say. And
Sharmila, sometimes, sometimes the baby is so stuck. There's no liker at all. And then, you put in your hand, you don't know what you're touching. It's the uterus is just holding your hand.
And the uterus is contracting.
Becomes difficult.
Yeah, very difficult.
Reverse breech becomes very difficult.
For me, always Patvardhan has worked. I've never failed with a Patvardhan. That's what my experience.
Yeah, but Patvardhan, you have to give a higher incision. You need to plan that before, right?
Yeah.
It has to be planned before.
What clamp? What?
Plan before.
Plan. Yeah. Anyway, whenever we go for a second stage cesarean section, it's always a Patvardhan for us. No planning, it's all plan. It is like always a predestined thing, because we know we'll have difficulty in taking out the head when it's deep impacted already. So there's one rare case which my friend has given the pictures of, Dr. Shanti from Mayavaram. This lady is a 30-year-old preemie with burn contractions in the abdominal wall, and she was treated with skin grafting. So Chitra, would you tell me, like, how do you plan for abdominal entry if cesarean is needed? There was also a laparotomy scar, and this is the umbilicus here near the this thing, almost like the pubic symphysis. The umbilicus is there. What are you going to do?
Ma'am, I think because there is a previous history of laparotomy, I really like to go with the vertical incision only. Okay. Not, I won't take up the transverse incision.
And suppose you go vertical and you have a case like Manju Puri madam showed, no, that full of adhesions in the abdominal wall. What will you do?
Yeah. So I think if it is adhesions, if at all I'm not able to enter the peritoneum, I think I'll go for the muscle cutting. Okay. In the that will be the better option.
Lateral this thing, and then
lateral muscle cutting. So that
anybody
will be the better option.
Yeah. Anybody would like to go for a transverse incision for this patient?
I would prefer a transverse incision because in a previous midline vertical, the adhesions would be more in the midline. Okay. And if I give a transverse incision, I would get better space in the lateral. Even if you want to go paravesical.
Because that's a school of thought, because laterally the contractures are there. You've done a skin transplant. You may not have.
Skin which is having these contractures. It's not inside. The patient has not been opened in a transverse incision. Laparotomy was this thing, and you expect more adhesions in the midline incision.
Okay.
And if I go with the transverse, I would get a better space.
Okay. So one vertical,
I'll also
one
go through a transverse. Yeah.
So two transverse, one vertical. Sarita?
I'll also go for transverse only. Transverse. There is no problem with the skin grafting done and all. Transverse will be much better.
What will you do with the umbilicus which is there?
I would also go for transverse.
Umbilicus? Sarita, there's an umbilicus there.
Yeah. Yeah, but we are going transverse. We are going transverse. Where are we reaching at?
So supraumbilical transverse. It will be a supraumbilical transverse.
No, it's not that way. You know, it's not that way. So umbilicus is because of the grafting, it has come down. That does not mean that umbilicus is displaced. It is not the rectus or the relationship of the internal layers of the abdominal wall is not displaced. You know, this umbilicus is here because of the skin grafting, and a skin graft is just about 3 mmD.
Okay.
Beyond that, everything is fine.
Okay. Asha, transverse or vertical?
Transverse.
Okay. Who else has to answer now? Doctor, everybody has answered. Okay. Anybody wants to put an opinion for this? Luckily for Shanti, she delivered normally, vaginally. They did not do a cesarean.
Good.
So the take-home message is, even though many of the panelists did not agree, the Joel Cohen blunt entry is supposed to be better.
Can I speak, Dr. Jamila? I have some patients who had previous cesarean with a Fannin steel. And I used to ask them how was their post-operative pain and all. They used to say we were not able to move and all with the Fannin steel. And with their consent, in the second, I went for a John Cohen, and they were much comfortable in the post-op period.
Okay, we'll take that as a take-home message then. Practically, please think over. You will feel that the Joel Cohen is much better. The low transverse incision should be considered even if the patient is obese. Routine creation of a bladder flap should be discouraged according to the guidelines. Low vertical uterine incision should be taken if there's a preterm delivery without a well-developed lower segment, or the baby is transverse, or the back is down, or there's a concern of placenta accreta. Hysterotomy should be extended bluntly in the cephalad chordate direction. No randomized trials are available to support or refute the use of tocolytic agents or instruments to facilitate infant birth at the time of difficult cesarean section. And for a deeply impacted head delivery, the reverse breech technique seems much better. I'd like to thank Dr. Mandakini Meg Madam, Dr. Mitra Saxena, and Dr. Sureka Taide. My request, Dr. Sureka, to take over the next part of the panel.
Please. Thank you, Dr. Charmila, for an excellent.
Thank you very much, Dr. Charmila, for charging the panelists so much. Now we are ready. They are ready for taking up the cases which we have devised for them. And here we are with the first case. Here, this case is for Dr. Richa, 28-year-old, second gravida with previous cesarean section, had preeclampsia. She was obese also. Huge ascites was there, pre-pleural effusion. Just 8 days back, we had this case. Blood pressure was 160 by 110. Started on labetalol orally, did not respond. Given IV labetalol, received magnesium sulfate. Ultrasound showed an umbilical artery had absent flow. completion of steroid. Estimated fetal weight was 1.2 kg. Now, the question is, what problems do you anticipate in this patient who is going to go for a cesarean section, and how would you manage this case? And during intra-op, we are talking of intra-op. Dr. Richa, please.
Surekha, I think Dr. Richa has not yet returned. So...
Okay, so anybody else who would like to take up? Dr. Promila, please.
Yes, this patient is having a early preeclampsia. I would like to have, at what gestation did she have the previous cesarean? Most probably it must also have been a premature.
Yeah, she had a premature cesarean section previously also. Now this is a small baby. The problem before you is how to deliver an extremely small baby and an ascites. What you would anticipate, how would you manage?
High risk for anesthesia also, considering her huge ascites, pleural effusion. She should have a pre-anesthesia consultation also, and all the investigations, LFT, KFT, HELP, coagulation profile before we take her up for cesarean section. And during cesarean, the problems we anticipate is because she is extremely premature, 28 weeks, the lower segment may not be formed properly, and the head will be free floating. If the lower segment is, and because of the previous cesarean, she may be having adhesions also. The bladder may be pushed up and adherent to the lower uterine segment. So we have to go very gently with sharp dissection. If the bladder, we find the adhesions of the bladder to the lower uterine segment to avoid any inadvertent injury to the urinary bladder. And if we are not able to go, we have to find a space in the paravesical area to reach the lower uterine segment. And once we reach the lower uterine segment, if the lower uterine segment is not very well formed, we may have to give a vertical incision in the lower uterine segment so that it does not extend laterally, and allow the liquor to drain. And if the head comes down, it's fine. If it doesn't come down, we have to deliver it with the internal potalic version as a breech, because we cannot apply vacuum in a premature baby.
Yeah, thank you, Dr. Pramila. Yeah, but yes, there was a large amount of ascites also here. This patient was quite obese also. So standard practice is to the position of the operating table. Yes. She may need a lateral tilt. And as you have rightly said, the anesthesiologist has to be ready, because once you drain that amount of ascites, she may go into hypotension. So you have to take care to inform the anesthetist about it and be ready for that. Retraction may be difficult. You need a good assistant also. Arrange for 2 drains. You know, that is a very good practical tip, because many times, you know, that large amount of ascites may not get drained with 1 drain. So, you know, you have to have that ready. Take care of the spillage. You know, large amount of spillage is coming on you. And that also is one of the, you have to be ready with that too, because everything coming on you and you may have problems. So wait for the ascites to drain before you give that hysterotomy incision. You know, there's no as such haste to go and just give the incision on the uterus. So that is a very important. LUS, as you said, may not be very well formed. Be very gentle with the delivery. You may have to do a reverse breech, and when you're extending the incision, you have to be very careful that, you know, because the LUS is not formed, and the uterine arteries, if they are just lying there, and they may get traumatized, because if you may have to use the scissors and curve the incision upwards. So that is very important. Again, the closure may be also difficult because the LUS is not so well formed. So let me tell you about this patient, that she was as you said, the LUS not well formed, ladder was very much advanced, and we had to give a proper sharp dissection for this patient. Around 1 liter of ascites was drained. Baby was only 1 kg, initially needed CPAP, and but now has come up, and only initially the oxygen support was needed. Mother had few biochemical and hematological abnormalities. Immediately the BP came back to the baseline. So these patients, you know, they respond very well when termination is done. And that is how this patient was very well managed by our senior resident. And we congratulate her for this very nice delivery of the baby. As you can see, the baby, you know, here we did not have much difficulty because it was not that much amount of floating head. The baby was small, the preeclampsia was there. That's why there was not a large amount of liquor. So the head was not floating at all, and we could very well do this cesarean section. So here I would like to show a small video here. When you go and do a cesarean section in this case, and you open up this case, you better use the scissor to curve upwards, instead of, just pulling with bluntly with the finger. So that is what is recommended when you when the lower segment is not well formed. So that is the message I would like to give from this case, that we should be doing this. Okay, so we go on, move with the next case, and this is for Alka. She's there? She's not there. Okay, so yeah.
This patient had an early onset severe preeclampsia with fetal growth restrictions. She may be having APLA, so post-operative thromboprophylaxis should also be given.
Yeah, that is okay. But what I wanted to focus was how to, the intrapartum part of. Very well said that she is going to require, of course, the thromboprophylaxis. This is a case again. She's a second gravida, 38 weeks of gestation, and yes, a previous cesarean section. As you can see in the picture here, that the she reported with cesarean with labor pains towards, had scar tenderness. The cesarean scar, as you can see, is very thin along its whole length, and you can see the anterior uterine wall is completely deficient, leaving. You can see the fetal membrane, the head is actually visible, and you can see the baby was seen moving beneath. So now my question to Asha, where would you plan the incision in this case, the uterine incision I'm talking of, and what precaution will you take during opening and closure of this patient?
See, the incision I would take would be on the, where it's already open actually. I don't have to take an incision. The incision is already open. What you are seeing is just the membranes and underneath the fetal head. So the membranes I would open with an artery forceps, and under the guidance of a finger would take it laterally and deliver the baby.
No, where exactly? So you want to be near the bladder, or here high up a little bit, or just in the center?
What you're saying is that this is all just membranes. There is no fetal.
No,
there is no uterus.
It's not the fetal membranes. It is, where you would like to,
where it is thinnest,
at least 4 centimeters over the margin of the bladder.
Yeah. So I just would like to give a message, ma'am, that don't be too near the bladder here, because that part is going to retract completely. And when you go and suture, that flap is not available. So just be a bit above. In this case, what happened, because it's so thin, and if you go nearer the bladder, the flap actually disappears, and you are not able to see that very well. That is what message I wanted to give here, that it's quite difficult, and you should stay above the bladder, quite as somebody has said, 3 to 4 centimeters above the bladder would
normally
be preferable.
If you are like 2 or 2.5, in this case, twice that length.
Yes, because it just moves below the bladder, and you're not able to actually pick up that particular flap. And sometimes it has happened that people have picked up the posterior wall of the uterus and sutured. That also we have seen quite a number of times, if that flap is not actually well created. And,
ma'am, sometimes
this patient, I would like to just show you. Yeah. So just wanted to show that when it's a previous cesarean section, it's better that you use a sharp dissection and create a good amount of, not for this patient, because already there was no wall left. But if it's a previous cesarean section, it is good if you can create a good amount of flap. See, many of you, we have heard that the bladder flap may not be created, but if it's very thin, it's nice that if you can create a good flap, and then, the closure becomes so easy and better, and the healing also is. So using a sharp dissection is always good to create that flap and suture. So that is what my experience is. This next scenario is for Dr. Sarita. This is the same patient. You try to open and the incision got extended laterally and there was profuse bleeding. You are the senior consultant now. There's a lateral extension. You find that there's injury. And now how do you manage this case?
So I was very fortunate to listen to Dr. Manju Puri just before. And she said very nicely, the first thing is you exteriorize the uterus. Don't try to search inside. Second thing she said is keep your hand behind so that you can feel the broad ligament and try to stop the bleeding if you can temporarily to see where is it bleeding. And then if it has extended laterally, you can take a figure of 8 stitch and stop the bleeding at the vessel. Sometimes you may have to ligate the uterine very carefully. And you at the same time, you have to be in touch with the anesthetist, tell them to give some tranexamic acid, tell them to maintain the BP, watch the parameters, ask for blood if required, and always ask for help. I feel that a helping hand is very important.
Yeah, thank you very much. And yes, Dr. Manju Puri has very nicely explained it. Just exteriorize the uterus, and that traction on the uterine artery itself, you know, you will be able to see something. Otherwise, such an amount of blood is there. Then that is this video. I would like to show you what happened to this patient. Yes, and of course, many a times it may be required that you may have to take the uterine. So this is how that the bleeding is occurring from there, and immediately that it has been. That bleeding has been taken care of. The clamps have been applied here. The ring forceps has been applied here. The bladder flap is created because we want to have some amount of uterine, you know, the lower flap there so that a proper suture can be taken off. And here I'm just showing the uterine artery ligation, how it was done in this patient. You put your finger behind the uterus and take a proper suture so that uterine artery can be ligated. Very nicely it is being shown that you are taking an avascular area where from you're putting the needle and the uterine artery is getting ligated here by passing the suture. There, be careful that do not pierce anything, the gut behind. That's where we put your posterior hand behind. So taking the uterine artery ligation, we usually do the bilateral. We don't go only for one. If it is required, we mostly would like to go for the second one also. So yes, for the uterine artery lateral extension, we usually prefer to do the uterine artery ligation. It saves lot amount of blood loss, as you can see in this patient also. So now, Dr. Pramila, this was a very thin uterus, and when you started to open up, you find that instead of going laterally, now it went below, and there's a vertical tear. And you came in as a consultant and you find that vertical tear, that whole thing get lost and you're not able to find it. What practical tips would you give to find that incision which has been lost below the bladder now? What are your tips for our audience?
Try to identify the location of the vertical extension and try to hold medial to that extension, the flaps which are visible, the uterine flap which is visible. And then try to see if the urinary bladder also has been injured or not in that vertical extension, which is very, very important. And then try to take the stitch, whatever is available, pull on that thread and try to go below if the apex is still below that. And do the bladder dissection with a sharp dissection. And I have to make sure by filling the bladder with methylene blue to rule out any bladder injury.
Yeah, thank you.
If the bladder injury is there, we have to see it is it's in the dome of the bladder or it is in the posterior part of the bladder. The dome of the bladder, we can stitch
in the next case. What take-home message is that whatever available with you, that part of the incision you need to pick up with your LS tissue forceps or whatever instrument you prefer to use. So what is visible to you, you can just pick up and then you trace. And as rightly said, you can just take a first suture and pull on that suture and you'll be able to see below. You will have to do a good amount of sharp dissection here because bladder is lying there and you have to just pushing with bluntly is going to injure the bladder. So doing a sharp dissection, being gentle, and of course taking care that you have not injured, and if you feel that there may be an injury, which it is better that you do the methylene blue test and intro up on the table itself so that you can see. So now I'm just going to show you this video where the lower segment had got extended. So whatever was available was just picked up by the LEs, as you can see here. See, this is the bladder, and this is the lower uterine segment. The injury, you can see the vertical one. It has been picked up. So you go below, and then of course you can suture and take that suture, you tie it, pull on it, and you can very nicely see that it is being done. And once you take that suture and pull on it, then you are able to go below it and very nicely, take the hemostasis. So it's important that good visualization is there. Here, the bleeding is not too much, but sometimes you may find that because of that blood loss, you're not able to see. So it's also very important that you have a good assistant who can suck out that blood and you are able to see. So very nicely, this video is able to show you the vertical extension which was there in this patient. Geeta, for you, yeah, Pramila. Did you say something which I didn't hear?
In the meantime, I'll call for a urologist for help if the bladder injury is detected, especially in the trigonal area or below.
We'll come to that, when to call the urologist or not, and we may have some difference of opinion in that. So we'll be coming to that later. Dr. Geeta, this is a 25-year-old. You did an emergency LSCS for contracted pelvis. She was in the post-operative period. There was increasing pallor, tachycardia. She was resuscitated with fluids. Within 1 hour, she collapsed. Now, emergent management was done for this patient, and patient was reopened. You find that there is a broad ligament hematoma. What practical tips would you like to give to, manage this hematoma? Dr. Geeta is there?
Sureka,
please unmute yourself.
Sureka, I wanted to say a very important thing at this juncture. May I allow to say
yes,
something?
ma'am, please go ahead.
Regarding the thin, lower segment, we had a very bad case and all the lower segment was lost. So we were very, in district hospital again. So what we did, we gave the lithotomy position to the patient, asked the staff to wear the gloves and, push it the vaginal wall and push it little upwards, and as soon as her hand was seen and whatever thin this thing lower segment we could see, actually we traced that by that method. Sometimes you have to use your original brain. I'm just telling my own experience. This is in
yes,
my own, yeah. And by pushing the hand, and whatever came on the hand was the lower segment, and we could suture it. I just
yes,
wanted to add my experience. Yeah.
This we used to have few years back, ma'am, when rupture uterus and all, that kind of obstructed labor was quite common. Nowadays, we are seeing on previous scars coming with thin lower uterine segment more common. But I can say even 5-7 years back, that kind of obstruction was quite common. Yes, this experience, and I have seen quite a few cases where the posterior wall itself was sutured and it was closed, and then we had to come back again and reopen and suture it again. So Dr. Geeta, are you there to take up this case of broad ligament hematoma? Anybody would like to take this case? Chitra, would you like to say something?
Dr. Sureka, one question has been going.
We'll take later on, Mitra, for you.
No, listen. Somebody has been asking how to suture the thin uterine.
Yeah, we'll take up that. Yeah.
So just remember to deal with that.
Yeah. Actually, what we do, we suture not with a when it's a very thin uterine segment, it does not require to be interlocked at all. As Arul had said, just approximation itself will work, and you may take some reinforcement sutures. So no need to pull on it too much, you know, because it's not bleeding at all. So that's very important to note. No need to interlock.
And even the suture method also, madam, it's better not to use the braided one because it might tear through the low uterus when it's thinned.
We don't use the braided at all, ma'am. Chitra, we don't use braided. Do you use braided material?
I'm sorry, I want not to use Vicryl. Vicryl you should not use. It's better we can use the catgut one.
No.
For that also, I may have a different opinion. We don't. Catgut is not available only. So we do.
Like
use
ours is a
Vicryl
ma'am. We get a lot of one. We are supposed to use most of the time catgut.
Okay, can you take this case, Chitra, about broad ligament hematoma which you have opened and how you would go about, you know, suturing it, and what practical tips would you like to give when you are dealing with such a case?
Once we find a broad ligament hematoma, we are going to open the anterior leaf of the broad ligament hematoma and evacuate the clots. Most of the time what happens, because of the hematoma, the bleeding point would not be able to visualize. So in those cases, on that area, we like to do the uterine artery ligation and followed by a deep closure of the area where we find the bleeding and put one sponge or a, what you call gel, ab-gel, and close this anterior leaf of broad ligament.
Perfect management. I think that was absolutely perfect. Open the broad ligament, anterior leaf, and see the broad ligament, the hematoma there, open it up and evacuate. And most of the time you're not able to see any bleeding point. You have to just open it up and evacuate. As you can see here, the cautery is used. People may not like to use the cautery. You can just open up with the scissors and evacuate the hematoma which is lying there, as you can see in this patient. But many a times it happens that even when you
won't help.
Exactly, that's what I'm trying to tell you. In this video also you would be able to see that they did go for the yes, they did go for the uterine artery ligation, but it was not enough. You know, just doing the uterine artery ligation may not be enough, and you may have to take few more sutures, few more hemostatic sutures will be required. So you can see here the hemostatic suture is being placed after visualizing the uterine artery and taking the suture. After that also the bleeding still continued and they had to take few more hemostatic sutures before that bleeding got controlled. And lastly, when we do any such case, you know, we should go and look posteriorly also. So that's one more tip. So as you can see in this case also, they went posteriorly to see whether any other, you know, anything else is remaining which may require your attention. So that is one more practical tips. So just don't look for the what is visible, you know, you have to go behind and see if there is any vertical tear or any other injury which may require your attention. So that was about a broad ligament hematoma case. Important things to remember is fit patient compensate for the blood loss by tachycardia and peripheral vasoconstriction. Vitus may remain stable for 12 to 18 hours. Also, even the peritoneal cavity may conceal this much amount of blood without increasing in girth also. So you have to be very vigilant in the post-operative period. You may think that you have done a very good cesarean section, but it may happen that your patient may collapse in the post-operative period. So just doing a cesarean section is not enough. You have to be very vigilant in the post-operative period. After 24 hours, the original blood vessel which was bleeding may not even be identified and general ooze may be uncounted. So just doing the uterine artery ligation is advisable in such cases. If you're not finding any ooze and there was the hematoma, then go for the uterine artery ligation. So the next case
Dr.
is
Sureka, Dr. Sureka, can I just make one comment here?
Yes, please.
Yeah, I know. I just like to say that today interventional radiology is there. So in case you pick up something post-operative when you have already closed, one of the options could be to, you know, embolize and stop the bleeding and the hematoma will reduce.
Madam, you're right, but then the interventional radiology setup is not present in most of the cases. Most of the setups don't have it. We have it in our institute.
Yeah,
we have it in our institute. Yes, it's an option. It's an option. But we are talking of the uniform, what to do. Most of the time it is not available in many medical colleges, and it's not available. Yes, you are right, you may, but it's good to open and see, because that's going to save a lot amount of time. And this kind of, the management is already what is called as a standard management. So this is another patient who was taken up for obstructed labor. The caesar was done, the blood was seen to be drawn up and adherent to the lower uterine segment. Indwelling catheter was kept for 72 hours. However, there was incontinence seen on the 4th post-operative day. Dr. Jagruti, what are our worst fears for this patient? Should bladder integrity be checked in such case intraoperatively? And what would you do if there is an injury? Would you call the urologist? Will you repair yourself? What is your take on this?
Yeah, first of all, as it is obstructed labor with previous cesareans, with the bladder adherent and IUFD, sepsis should be kept in mind. And for the 3 post-operative days, the patient was better. And on the 4th post-operative day, she is having incontinence of urine. So we have to, the bladder trauma comes first to my mind. But then also you have to rule out retention of urine post-operatively, and whether the patient is having retention with overflow. After ruling out that, we have to keep in mind bladder injury. So bladder injury may have taken place at the time of cesarean section. It may have gone unrecognized, or there may not be any injury, but still because of obstructed labor and IUFD and because of sepsis, the bladder wall may have sloughed out, and because of avascular necrosis, and rent may be present in the bladder. And that is the reason for the incontinence of urine. Now, whenever you are doing a cesarean section and you are in doubt that you have done an injury to the bladder, or you are in a doubt, then always check for it. Do a methylene blue dye test, fill up the bladder and see whether there is any leak or not. Or you can go for cystoscopy also. Now, at the time when you do the methylene blue dye test and you see there's a rent in the bladder, if there is a small rent, you can suture out in 2 layers with a Vicryl 30 and leave the catheter for 7 to 14 days post-operatively. If there is a big rent, now identify the rent, where it is, like it is near the ureters, at the base of the bladder, or in the dome of the bladder. So according to that, you have to now carry forward the procedure now. If the rent is near the ureteric opening, do a cystoscopy. Before that, you can do a cystoscopy and see how much big the rent is, or you can directly.
Do you do that cystoscopy yourself, Jagruti? Have you have any experience of that, or would you like to call in the urologist in this place?
Yeah, we have got a surgeon associated with us, so many times he helps out in doing the cystoscopy.
Yeah.
So do a cystoscopy. But I'm talking of at the time of surgery, if we would have recognized the rent, and if it is near the ureteric opening, then you have to pass the ureteric catheter. Maybe at that time, we as a gynecologist and obstetrician don't have ureteric catheter. We can pass a thin infant feeding tube, negotiate the ureteric catheter, and if we can take care of the suture, we can do it in 2 layers. But otherwise, we can, at this place, we can call a neurologist, because then it is necessary to catheterize both the ureters and suture the rent in the urinary bladder.
Yeah, but quite a few times, if it's a previous cesarean section, the rent may be, small, and we may be able to dissect out. So the principle would be to dissect that area away. Properly, the bladder has to be dissected from the lower uterine segment, and then maybe take the sutures if you want to take it yourself. And even I have seen a case when my SR actually opened up the uterus through the bladder, and such a big, huge rent was there. The baby was taken out from the uterus and the bladder. So that big rent also we have seen, and it could be managed well. Many a times, as you rightly said, we have to locate where the ureters are, and a cystostomy is needed, and you may call either the surgeon or the urologist. Many a times they are there in our team, and it's good to call them because medical legally also it is safe. Dr. Sarita, you'd like to add something? You were,
No, I agree perfectly with what Dr. Jagruti said. And I think that, if it is a small rent, at that time, you can close it on your own because, but if it is a bigger rent, if you feel you have gone near the trigone, ureters could be involved, then it's always safer to call somebody.
Yes, and yes, it's quite, it's suturing it is not that difficult actually. Even if you open up the bladder and there's no need to panic. The suturing is, we are surgeons and we know how to do that suturing as maybe 20 or 30 of your suture material is required, and you can very nicely suture it, and the bladder can be, the catheter can be there for 7 to 10 days. However, I think it's good that you should recognize if the injury is there intraoperative itself. That will reduce the morbidity quite a lot. So just showing this small video here, yeah.
One important thing, when the bladder is adherent to the lower segment, we should avoid using cautery because thermal injury can also lead to the bladder injury later on.
Mostly we do not use the cautery at all, and we use the scissors only. So see, can you see very nicely? You can see the bladder. It's very. You should be able to recognize that this is the bladder and nothing else. The visually also you are able to very nicely see that it's the bladder. In this case, they have decided that it's a small injury, and they are using Ellis tissue forceps, but I would prefer to use the Babcock's. We have been traditionally also taught that you should be using the Babcock's tissue forceps to hold the bladder edges, and they are using the 20 material and closing the rent themselves, as the injury is quite small. But I would advise that the bladder should be nicely dissected away, and then the suturing can be very well done. So that is a small bladder rent which is seen here and is being sutured on its own by the operating surgeon. So yeah,
if the bladder injury is in the trigonal area or below, it must be done under cysto-ureteroscopy by a urologist, because ureteric orifices and urethra must be taken care of under direct vision. In that case, urologist must be involved.
Yeah, but see, in this case, it was a very small rent, and we can very nicely put in our finger inside and find out where. So it's almost it's in the dome. And it's mostly the ureteric orifices are not involved in this case. But where you suspect that the ureteric orifices would be involved, I agree with you, either the surgeon or the urologist, whoever you may, should be there with you. And medical legally also, it is good that you should involve another person who would be there with you and would help you to take care of the case. So that's the take home message from this case. Now coming to the last case, and that is for Chitra, third gravida, one cesarean section. She had an uneventful cesarean section, no unusual adhesions. Patient discharged on the 4th day comfortably. 12 hours later, rang up the consultant from home that she is having pain and she is having vomiting. Patient was asked to return to the hospital. Another delay was of 4 hours, and then she arrived there. Now she's uncomfortable. Tachycardia is there. Temperature is there. Respiratory rate also increasing. And there's an abdominal distension. She's there's tenderness in the abdominal also. What do you suspect, and how would you go about managing this patient?
Actually, previous LSCS uneventful and no adhesion mentioned. So previous LSCS, most of the time we feel there might be some adhesions. So according to the history, what it suggests, it can be involving of the GI system. Because patient is having vomiting, distension, so can be some injury to the bowel could have occurred, or if at all, if it not mentioned, some bleeding, I think some foreign body would have been left behind. So it's better we get one ultrasound done and do the chest X-ray and find out any instrument has been left behind or any mop has been left behind, or to find the gas under the diaphragm to rule out any intestinal bowel involvement.
Yes. So, yes, this case actually, with the distension of abdomen and the pain and vomiting would suggest that there is some part of sort of bowel involvement, and definitely we managed this case with the X-ray was done, the gas under the diaphragm was seen, and perforation was suspected. The patient refused to do a laparotomy and had to be referred, and there was a cecal injury seen, and then colostomy also was done, and she was saved, of course, and there was a litigation in this case. So better, when you have, do you think that this could have been predicted and detected early? Any of the panelists, please? Do you think you can predict any such injuries?
Cecal injury is very rare.
I think this is a very rare situation and in all these years, I personally haven't really seen a GI injury caused by at cesarean. But of course, anything can happen. And the only comment I would say is that if somebody comes like this, do CT abdomen, because CT abdomen is excellent for bowel. And if you take any surgical opinion, the first thing they will ask for is CT scan.
Yeah, I agree, madam. What you have said is very correct. That see, what we are doing is we are not touching the bowel at all. What kind of cesarean section and the Misgav-Ladaf technique? What we are doing, we don't even put the packs. We don't advise the packs also. We don't see the gut also. So many a time, yeah, I agree that if there are adhesions, and then maybe when and the opening itself, you may find that if there are a lot of adhesions, then there is a case of the bowel injury may happen. Vigilance should be there. If there's an obstructed and prolonged labor, then you may find that the bowel is pushing too much, and that is the time you have to be very, very careful. Best manage on the table if you can detect it on the table. If detected late, then of course there are some problems, surgical problems and medical legal problem. Like this case had a colostomy. She had to undergo a colostomy, and there was a litigation in this case. So what take-home message I would like from this panel is cesarean delivery comes with a package. It may be good, it may be bad, and it may sometimes turn out to be ugly. Be prepared, decide wisely, tackle effectively. And yes, if somebody asks me, what do you do obstetrics? How much obstetrics do you do? So we do obstetrics 24/7 and 365 days of our lives, and that is what even we dream of, I think. So obstetrics runs in our blood, and thus whatever it gives us good, fine, but we should be able to tackle the nasty situations also effectively. With that, I would like to hand over and for final comments from Dr. Mandakini.
Thank you, Dr. Surekha.
Yeah.
Thank you.
Neha, please stop sharing the.
Yes, ma'am. I'm trying to find where it is. Yeah, done. Your comments, ma'am.
Yeah. So it was a very excellent panel and very practical. Surekha, you have given such a wonderful, cases where anybody can actually come in, and we have seen so many times of bladder injuries along with the rupture uterus dome of the bladder. And I think everybody here who is actually doing the obstetrics, as you said, it is in our blood, and that is why we are here by up to 11 o'clock. And some of the faculties which could not attend, they were because of the obstetric emergency. So everything is in obstetrics. We are hardcore obstetrician, and we take pleasure in being the obstetrics. Today was a wonderful day. I want to thank each and every one of you. Surekha and Charmila doing a great job. And I think you can see here up till now 600 people were attending. Now also almost 350 people are there. It itself shows the content, the practical tips, and very, very useful of this course. So very great congratulations. I will come to the inauguration was done by Dr. Virkud and Dr.
Kamal Bakshi.
Kamal Bakshi gave a beautiful tips. And here I want to share with you what she said, that we should be fighting for the doctors. That one message again I want to say, and we should discard the film personalities, because nobody has come forward to help the doctor in such situation. That one message really, was very, very heart touching. And also Dr. Virkud gave another message, that doctors should find out some alternative method and develop some other skill to earn the money. Maybe it is looking little different, but these two things came out in the inauguration. After that, the faculties were excellent. Jaideep Tank, Arul Kumaran sir, Manju Puri, everybody, and see the comments. Snehala has already said that comments are full, and everybody is giving suggestion. You should keep the course. You should keep it for 5 days. And wonderful day again. Tomorrow we meet. Now I can't give the instruction to the attendee because many of them have left. So third day, tomorrow we'll be giving the MCQ at the end of the session, and you all have to solve the MCQ. When you get 50% of the marks, then only the certificates will be issued after 15th day. So I think with this, I take opportunity to thank Surekha, Mitra, all the excellent faculty, and the night birds of the this panel discussion for being there with us and making it very, very interesting.
Thank you very much.
Thank you, ma'am. Thank you, Charmila ma'am, Surekha ma'am, for wonderful moderation. Thank you.
Thank you, everyone.
Thank you, Dr. Snehala Dambal requires special mention. She has, moderated things very beautifully. And also Aditi Tandon. So with this, I think we sign off. Family is waiting for dinner.
Thank you, ma'am. Thank you, everybody, for staying up till 11 o'clock. So it tells everything.
Tomorrow also we start at time, but end we don't know. So no problem. Tomorrow
it will be fast.
I'd like to thank my co-moderator, Dr. Surekha. Thank you so much, and all the esteemed panelists who have paneled.
Thank you so much. Thank you, Dr. Charmila. Thank you, Dr. Surekha.
Thank you, Mandakini ma'am, Dr. Mitra ma'am. Thank you so much.
Can you take a photograph, please? Anybody?
Yes. Video on for photo.
Photograph.
Jazia is there. Please take photo.
Yeah. Photo. Because we want to keep it for the record. I see.
Mandakini ma'am, but lot of love from all of us.
Thank you.
I think this thing from all of us.
We learn from you, your enthusiasm.
Yeah, thank you very much. And I get inspiration from the young generation. Everybody, my husband is saying 4 o'clock till now you are sleeping and you are not using the washroom also. What is this? I'm sorry to be little intimate question, but I'm senior. I can take the
recording. The recording is going on.
I'm so sorry. I will ask him to cut it.
Thank you, Sheila. Thank you, Sheila, for a beautiful.
Bye. Good night.
Thank you so much.
Thank you so much, everybody.
Thank you,
Good
everybody.
night.
Good